on the regular agenda if if you're in the room with me.
All right, sounds good. Thank you.
Thank you.
Good afternoon, Michelle. Would you like to do a mic check?
Sure. Are you able to hear me okay?
I sure can. Thank you very much.
Thank you.
Hello, Miguel. Would you like to do a mic check? Hi, Renee. Would you like to do a mic check?
Yes, how you doing? Can you hear me?
I can hear you and see you. Looking good.
Okay, thank you. Are we keeping the video on or is it turning it off? You know,
Totally up to you.
totally up to each one of us. Okay. I'll turn it off for now. Okay.
Hi, Rhonda. This is just the mic check from Miguel, and Jeff and I are both in my office on a different call, so we'll join right at 2 o'clock as well.
All right, I can hear you loud and clear. Thanks for the check-in. Hi, Doug. Would you like to do a mic check?
Sure. Can you hear me?
I can hear you loud and clear. Thank you.
Great. Thank you so much.
Good afternoon, Supervisor Sumedian. Would you like to do a mic check?
This is Supervisor Sumedian. Can you hear me now, Rhonda?
I sure can. Thank you very much.
Thank you.
Hello, everyone. Just a friendly reminder from the clerk's office that the meeting will be going live shortly. Thank you.
Good afternoon, Sherry. Would you like to do a mic check?
Sure. Good afternoon. This is Sherry Terrell.
I can hear you loud and clear. Thank you.
Yeah.
Is that Liz Nis on video? Hello?
Yes.
Hi, Liz. For some reason, you came up under Supervisor Midian's name. Luckily, you had your video on and I recognized you, so I'm going to rename you.
Thank you.
Liz.
You are welcome. Otherwise, I was about to boot you.
Maybe I'm Josephina.
Now, you get to be Liz Nis. That's how we know and love you. Thank
Thanks.
you. You are now Liz Nis.
Thanks for coming to my rescue.
Anytime.
Hi, Susan.
Hi, how are you doing?
Good. I'm
It's
just
nice
going
to see you.
good to see you. I'm going to see if I can get in a better. I haven't quite learned how to pose for Zoom yet. I only know that I just know a few things. I think I need a Zoom course. Oh, good.
I've definitely improved my skills over the last few weeks.
Yes. And you look very nice on top of it.
Well, thanks.
I've realized though that it's kind of like, you know what they used to say, when the dog's on the computer, you don't know who's really on the computer. Whereas with Zoom, you really do know who's on the computer, and you kind of have to think about what you're going to put on before you get there.
This is true, but there are all kinds of cool backgrounds, so people don't necessarily have to know where you are.
Yes. And you know what I discovered though? My computer is so old that I can't get a virtual background. It doesn't have the capacity. So we're getting a new computer. It's a good reason to do it anyway.
Well, your background looks just fine.
Thank you. So you have, I don't know which, I usually have a background picture, but I don't see one today. I think I may have lost it. No, I've lost it. You know, you can put a background picture in so that when you go when you stop your video, you can do that. But I'm an attendee today, so I need to find out how to ask questions. That will be interesting.
Rhonda can definitely help you with that.
Okay, good. Okay, well, I'll just stand by.
All right. So to make sure that you had the appropriate permissions, I went on ahead and did make you a co-host. If you look over, if at the very bottom of your screen, there is a icon that says participants.
Uh-huh. Do you want me to hit that?
Yes, and just to let you know, we are being recorded just because we're getting ready to broadcast. So I just wanted to be upfront there. So
Yeah.
when you hit the panelists and then you scroll to the very bottom,
Mm-hmm.
there should be a icon to raise your hand.
There isn't, and I'm very familiar with that, so I don't know why. Because you have me listed, I think, as a co-host, I have the ability to mute everyone and unmute everyone.
Yeah, so hold on, I'm gonna remove that and hopefully that raise the hand will come back.
I think that's probably what would happen. Yes,
All
I've
right,
got the raised
you are
hand.
now a guest.
Uh-huh, thank you. And I can raise my hand, thank you.
Perfect, sorry about that. All right, thank you.
Hi, Rhonda. This is Renee. I see my name twice, and I don't know who's the other one, by the way. So you may want to double check.
I only see it once.
Renee, this is Bert Margolin. Do you hear me?
Bert, you're showing up as the Renee Santiago.
Yes, I figured it was me. I was looking for my own name. I couldn't find my name, and now that you've identified yourself as being here twice, I think I'm you. The
Bert,
second time.
Can you please spell? I'm gonna change your name right now. I have the spelling, so
Sure.
give me one moment and you will be Bert.
All right. Thank you very
Thank you
much.
for identifying yourself because you almost got booted.
Thank you.
Rhonda, can you hear me?
Yes, Miguel, I can hear you.
Great. Just wanted to let you know that again, Jeff Smith is here in my office, so he's available.
Thank you. Just a reminder to all in the room, we are currently being recorded and we're broadcasting on IQM2. Tony, would you like to do a mic check?
Can you hear me?
I sure can. Thank you very much.
Hey, I'm gonna unmute or mute.
Rhonda, this is Supervisor Simidian. I know we're a couple of minutes past start time as we deal with a few of these technical issues. Are we ready to begin, or would you like another couple of minutes? Either way is just fine.
If you could give us a couple of minutes, I do need to just verify a couple people who have entered the room.
Great. Why don't we give you a couple of minutes and I'll circle back in 2 or 3 minutes, or you can just let me know that you think you're ready. We're ready to go. Okay.
Thank you so much.
Thank you.
Hello, Dr. Smith. Would you like to do a mic check?
Hello, can you hear me?
I sure can. I just needed to verify that was you since I knew you were also somewhere else.
Well, Miguel and I are in the same room, but he's on the computer and I'm on the phone, so we'll be talking over the phone, but watching over the computer.
All right. Well, thank you very much. Hello, Laura. Would you like to do a mic check? All right, Supervisor Samiti and I have verified everybody in the room, and we can go ahead and start the meeting.
Thank you. Give us just one more minute, please.
Hello, it's Andrew James from custody. Can you hear me okay? Just doing mic check.
Yes, thank you. We can hear you.
Thank you.
Hi, this is Laura Rosas. Can you hear me now?
Yes, Laura, we can hear you. Thank you very much for checking in.
Thanks so much.
And at this point, I'm going to actually formally convene the meeting and call the meeting to order. This is the Santa Clara County Board of Supervisors Health and Hospital Committee meeting, regularly scheduled for this time by virtual teleconference. And having called the meeting to order, let me ask the clerk to first call the roll to establish the presence of a quorum.
Chairperson Simidian,
Simidian present.
Vice Chairperson Ellenberg.
Here.
Thank you. Have a quorum.
Thank you. Quorum having been established, that takes us to item number 2. Item number 2 is to allow for public comment. Let me ask the clerk's office, do we have speakers queued up for public comment? And if so, may I ask how many, please?
Yes, we have 2 speakers in the queue. So
Thank you very much. Well, let's go to those 2 speakers, and we'll give our speakers under public comment 3 minutes, as is our custom and practice when there's a relatively moderate number of folks who are queued up. So why don't we go to you, Mr. or Madam Clerk, and let you welcome in the first speaker.
okay, the first speaker is Scott Largent. I'm unmuting you. Please accept the unmute, and you'll have 3 minutes to speak once the timer begins.
Thank you, everybody. Good afternoon, Scott Largent. First off the bat, I do appreciate Supervisor Simidian giving us the 3-minute public comment. At some of the other meetings now, Supervisor Chavez has hacked that down to about a minute. Some of them are at 30 seconds. So I very much appreciate that. So after 9/11, we figured out that the CIA, the NSA, and the FBI were not communicating with each other. Okay, there was a lot of holes in the system there, a lot of things slipped through the cracks, and the public was pretty upset about that. And, you know, over time, they got their act together. In Santa Clara County, I believe, and I know this for a fact, that the law enforcement of the different cities are not communicating very well with behavioral health. It's the same thing. Basically, it mirrors what happened, during 9/11. I think our behavioral health system is a disaster. Okay, nobody is being put on the proper holds. This was prior to the COVID-19 issue. I'm sure our county is going to blame it all on COVID-19 as we keep requesting more and more funds from the federal government. This disaster was there before, just like our homeless issue. We are now not taking care of the people that need our help, the people that have it the hardest. Judge Stephen Manley, excuse me, no longer sees cases right now of anybody that's on an outpatient situation. So they're not kind of keeping tabs on people that have severe mental health issues. We just let them basically back out into parks and sides of roads to scream, to yell, to defecate. When you look in their eyes now, it is so sad. It's just desperation. And I am capturing that. I spend a lot of time out on the streets right now talking people off the cliff. Nobody from the county is out there. Why are you people so scared? Okay, this kind of mirrors also when the AIDS epidemic came out in the 80s. Everybody was terrified to go around an AIDS patient or somebody that had HIV. Why are you people so scared? These people need our help right now. I am very frustrated. I'm out there doing as much as I can. And, you know, I'm putting my health at risk. A lot of other activists are doing the same thing. Robert Aguirre, Richard Scott, And you know what the sad part is? These people are heroes in my eyes, and you don't even treat them like first responders. It's like you want them just to kind of go down the hill. I don't understand it. So I'm disappointed in Santa Clara County. Thank you.
And looking to the clerk's office, our second speaker is who, please?
Gina Gates. I am unmuting you. Please accept the unmute and you will have 3 minutes to speak once the timer.
Good afternoon. Can you hear me?
Loud and clear.
All right. Good afternoon, all. And thank you for all of the work that you're doing and the sacrifices your family, like mine, are making. I'm reaching out to you in regards to COVID testing, antibody testing. My name is Gina Gates. I'm with Gates Consulting Group. I've been working in the community for many years now. And so kind of I moved forward on starting to do testing because the sector that I deal with just could not wait anymore, which is the Latino sector. And so we've had already our second, actually third COVID testing that is going on today over at the Union, LaUna. It's been received very well, and I think it's been dealt with in a very smart fashion, where Union is actually looking at how their first responders, or rather, I guess that's a little bit much. Their required folks are passing out food and dealing with folks in need from their union and community, how to take care of them and create a baseline. So with that being said, we have expanded now. We have another test at LaUna tomorrow. We have 2 scheduled for next week on the 4th and the 7th, hosted by Councilmember Magdalena Carrasco. Again, looking at serving the community, the Latino community, in a way that makes sense. The way I've been organizing for many years is we go and meet people where they are at. And that is how this is going to work. So I'm reaching out to you today specifically because the San Jose city manager announced to the council that Verily was going to be doing testing at Pell, and I think that's a super great idea. And we want to make sure that the work that we have done is reflected in there, that you know about it. I know I bugged Cindy and I bugged Steve about what we're doing, and even had conversations with folks over at the county health department. We were very careful to use an assay that the county health department had confidence in. And we did want to use a rapid test, but they weren't confident in it. But we wanted to make sure we were doing what the county wanted. So we're doing good work. I would like your attention on our work and see how we are going to fit in this bigger picture. Again, Verily is a big company. We're just a small company. My partner is actually works in the lab industry for many, many years, dealing with cancer and other big issues. So again, Gina Gates with Gates Consulting Group, please follow up on my work. Thank you.
Thank you, Ms. Gates.
And Supervisor?
Yes, Madam Clerk.
Yes, Liz Niss does have her hand raised to speak as well.
And let me just ask Councilmember Niss, former Supervisor Niss, if she would like to speak now, which would be perfectly fine, or if her comments relate to COVID testing, whether she'd like to speak when that item comes up. Either is fine, but we do ask folks not to double dip. Okay. Supervisor / Councilmember Niss, what's your preference?
Need to be unmuted. Thank you.
Thank you.
Yes, I was going to ask whether or not that was on the agenda because I don't have an agenda. My apologies. But yes, thank you for asking, Supervisor Simitian, and I prefer to speak on the COVID-19 item.
Great. We do have a verbal report from the public health officer. That is item number 6, and it's my expectation that that will be primarily, if not exclusively, devoted to the COVID-19 issues. So I'll ask both you and the clerk to be mindful of that when we get to item 6, and I'll make a note to myself as well. Thank you. Madam Clerk, any other speakers under public comment, please?
This concludes the number of speakers.
Thank you. And Let me just say then that that concludes item number 2, which is public comment. It takes us on to item number 3, which is to approve the consent calendar and any changes to the committee agenda. Given that folks are participating virtually, I'm going to be a little bit more detailed in describing the consent calendar. Supervisor Ellenberg, just so folks know that as things now stand, items 10, 11, 12, 13, 14, 15, and 16 are all contained on the consent calendar as proposed. Again, that's item 10 through item 16. And let me just ask at this time, Madam Clerk, if anyone has indicated a desire to have any of those items pulled or to speak to item number 3, which is the consent calendar.
No requests so far and no speakers so far.
Thank you, and forgive me for Madam Clerking you repeatedly. Then, without objection, we will approve the consent calendar as contained in our published agenda. But given the virtual nature of the meeting, I'm going to be a little bit more formal once again and ask Supervisor Ellenberg if she is prepared to move approval of the consent calendar as contained in our published agenda.
So moved.
Motion by Ellenberg, second by Simidian. Would the clerk please call the roll?
Excuse me, Chairperson Smitty, would you like to take the one speaker with the hand raised?
Forgive me, I did not see that we had one speaker, but we're happy to take that one speaker, and that one speaker will have 2 minutes.
The next speaker is Gina Gates. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak once the timer begins.
Please excuse me. I was actually looking at an item further down the road. This is new for me, and I didn't realize that we were going to be talking about COVID and testing. So I would prefer to have had the option to speak then. So I'm sorry, I don't mean to take up time now.
Not a problem. Thank you. All right, then going back to our clerk, I believe that was all of the folks who had perhaps indicated some interest in our consent calendar and speaking on those items. Yes?
My apologies, Mr. Chair. We have one more hand that just went up, Mr. Scott Largent.
All right, we're going to make that the last one, and we're going to turn to Mr. Largent, who will have 2 minutes. Again, Mr. Largent will be the last speaker on the consent calendar, please, today. Mr. Largent.
Thank you, Supervisor Simidian. You're a good man, and I really do appreciate what you're doing right here, allowing the public to participate. Maybe this is just a suggestion right here. We could go over what the items are that are being pulled off of consent. Now, the reason I say that right now, the other woman that was on there, Liz, kind of brought it up too. She doesn't have a hard copy of the agenda. I'm not trying to make fun of her computer skills. I'm a little out to date. You know, I've been out of the gig for about 5 or 6 years. Kind of trying to multitask, got the smarty phone, even though it's a Note 9 phone, rotating back and forth and trying to look at the agenda, not having the computer in front of me. It does make it a little more difficult. So maybe we could just go over saying, hey, this item 9 is about the, the jail. Line item 10 is about this. And that might just be helpful right there. I do appreciate that right there. This is kind of running a little differently than the first 2 or 3 weeks. And I do appreciate what you're doing. And I will try to keep my mouth shut and not burn up too much time. So thank you.
All right, thank you very much. Let me ask first the clerk. That should be the end of the list for folks who have signed up to speak on the consent calendar. Is that correct?
That's correct.
Thank you. And then I think the request is a reasonable one. So let me just indicate item number 10 is the report from the Emergency Medical Services EMS Agency relating to a revision in the EMS Trust Fund spending plan. Item number 11 is to receive the report from the County of Santa Clara Health System relating to Enterprise Fund and General Fund financial statements. Item number 12 is to approve policies and procedures for the Santa Clara Valley Medical Center hospitals and clinics. Item number 13 is to receive the report from the Valley Health Plan relating to activities, opportunities, and progress. Item 14 is to receive the report from Working Partnerships USA relating to healthcare reform implementation public meetings. Item number 15 is to approve the minutes of our March 18th, 2020 meeting. And item 16 is to receive the report from the County of Santa Clara's health system relating to items pending for the Board of Supervisors. We do have a motion from Supervisor Ellenberg, a second from myself, Supervisor Simidian, for the record. And at this point, we'll ask the clerk to please call the roll so that we can move on to the next item.
Chairperson Simidian,
Aye, Simidian, aye.
Vice Chairperson Ellenberg,
Yes.
And then if the clerk is logging that, that's a 2-0 vote since we have to be a little more formal today as a matter of good record. Then that takes us to our regular agenda. And again, just to help those who are working without an agenda, we have items 4, 5, 6, 7, 8, and 9. Item 4 deals with medical staff credentialing. Then item 5 is a fleets and facilities report regarding the behavioral health services facility. That is a work in progress. Item 6 is to receive the report from the public health officer. That's the time when I anticipate we'll have significant COVID-19 discussion. Item 7 is, however, also COVID-19 related, and it's a report from Custody Health Services related to COVID-19 and measures taken to prevent, spread of the virus. Item 8 is to receive a report from the County of Santa Clara Health System relating to community-based health clinics. And then item 9 is the various recommendations relating to emerging issues regarding the County of Santa Clara Health System. And at that point, we will hear from probably a half dozen of our various department and agency leaders who will just give us an update on various items pending before us. So that takes us to item number 4. And if we could ask the clerk to read the item one more time, please, and let us know who's going to present. To the clerk, please.
excuse me, I believe the presenter is going to be Dr. Yvonne Karanis.
All right, then we'll welcome the doctor and ask for the report.
Good afternoon, Board of Supervisors. My name is Yvonne Karanis, and I am the Enterprise President of the medical staff. And I'm here to present several items for approval, including the credentials report, as well as several actions that have been taken on by the medical staff to address the COVID-19 pandemic. And these include the temporary telemedicine privileges for medical staff members and allied health professionals, the temporary telemedicine privileges for optometrists, nurse practitioners, licensed clinical social workers, physician's assistants, and nurse anesthetists. And please note these temporary privileges were granted for 30 days, starting on March 20th. So they did come due for renewal on April 19th. And that renewal will be coming to you for approval in the next Board of Supervisors meeting. Also to approve the suspension of secondary site approval and onboarding process, and also to approve the temporary expansion of privileges for current medical staff members with internal medicine privileges and members with psychiatry privileges.
Thank you very much. Does that complete the report?
Yes, thank you.
So just for the record, we have items 4A, B, C, D, and E before us. Let me ask the clerk if we have any speakers lined up, virtually at least, to speak on this item.
No speakers.
Thank you. Then I will look to Supervisor Ellenberg, see if she has questions or comments, and if not, ask for a motion at this time.
I do have a couple of questions today, Supervisor Simidian. Dr. Karanis, nice to hear your voice. I can't see you on there, but hope that you're doing well. To date, as part of the COVID-19 response, has the medical staff actually needed to call on providers to serve in acute care or inpatient settings as outlined in the policy for temporary privileges? Meaning, have you needed to use the extended credentials?
We have not yet.
Oh, well, that's good news. And has there been any need to make changes in medical staff policies or assignments to support custody health due to the COVID-19?
Not yet, not as of this date.
Okay. So it sounds like we're working well within our normal capacity in terms of personnel and staff.
Correct.
Great. I don't.
to anticipate a possible surge.
So I'm sorry, say that again. I talked over you.
Sorry, we are just working to anticipate a possible surge of patients.
Right. And I appreciate that. Thank you. I have no further questions. So at this time, I'm prepared to make a motion to accept the report.
Thank you very much. The motion is to not only accept the report, but just to verify for the record to approve the various appointments and expansion of privileges and as contained in items for A, B, C, D, and E, correct, Ms.
Correct.
Ellenberg?
Thank you for clarifying.
With that motion, I will second and confirm once again with the clerk that we had no speakers on this item.
That's correct, Mr.
Thank you very much. Then we'll ask the clerk to please call the roll to establish the vote for the record, please.
Chairperson Simidian,
Simidian, aye.
Vice Chairperson Ellenberg,
Yes.
And I'm going to guess the clerk is going to confirm for me that that item passes on a 2-0 vote. Is that correct?
yes, that's correct. Excuse me for the technical difficulties.
No worries whatsoever. Thank you very much. That completes item number 4. Takes us to item number 5. This is to receive a report from the Facilities and Fleet Department and regarding the Behavioral Health Services facility, including the inpatient child and adolescent psychiatric services. So I see that the memo comes to us from both Mr. Draper and Mr. Lorenz. Gentlemen, who'd like to lead off with that presentation?
Thank you, Chair Simidian. Paul Lorenz, Chief Executive Officer for Valley Medical Center. Obviously, in your package, you have the report. In that report, we continue to track to the timeline as you have reviewed in previous board meetings. I have Jeff Draper here who can comment further on the progress today.
Hi, Supervisor Simidian. This is Jeff Draper from the Facilities and Fleet Department. As Mr. Lawrence just told you, we're tracking very well. Had several design meetings and progress is coming along nicely at this point. We're very happy at the April 21st meeting that the board approved some additional resources to keep the design on track, as well as authorized us to award the CM or to advertise the CM at risk contract so that we can have the potential construction contractor help us with the design early on in the particular project. I think that will help expedite things. With that, I'm done with any other additions to the report.
Thank you very much. I know at past meetings, we've had the benefit of having Mr. Koenig and Mr. Ohashi, and I believe it's Mr. Sodi. Am I pronouncing all three of those names correctly, by the way?
They're correct. And we have Mr. Ohashi and Mr. Koenig here in the room with us.
Okay, so as has become the custom and practice at these meetings, I'm going to continue to indicate, particularly under the current challenging circumstances, that the staff report has continued to indicate design completion is scheduled for February 2021. Construction begins February 2022, open to patients November 2023. Mr. Draper, let me confirm that's the same schedule we've seen now for the last 2 or 3 meetings, yes?
It is.
So Mr. Draper, and I hope folks will just bear with me during this exercise, is it still your view that we can and will meet those deadlines as ambitious as they are?
It is.
Mr. Lorenz, do you share that view?
Yes, I do.
Dr. Smith, can we still meet those deadlines? And is it our intention and plan and expectation that we will?
It is our intention and plan, and we think we still can.
Thank you. And I hear that Mr. Koenig and Mr. Ohashi are on the phone. So Mr. Koenig, same question for you. Is there any reason, well, I'll frame it positively. Do we continue to believe we're going to meet those deadlines?
Yes, I did.
Thank you. And how about you, Mr. Ohashi? Don't want to leave you out.
This is Curtis Ohashi, and the answer is yes.
Thank you. A couple of other slightly more substantive questions. Number one, I do want to acknowledge the progress that's been made to date, express my appreciation for that. I think the selection of a site, the allocation of funds, the approval for the construction manager at risk, the work to date on financing options, all of these are things that are tangible and necessary steps forward. I also appreciate the staff's willingness to reach out to the folks at Oshpod, and after having assessed the potential for some interim use at the O'Connor Hospital, could somebody just chat a little bit about what we think the prospects are there and what the status of that interim use exploration is?
Supervisors, this is Jeff Draper. I would just say that look possible. There's a possibility of taking a 24-bed suite and using it for, I think it's 12 regular beds and one isolation room, so 13 beds total. Obviously, that takes additional money and time. The downside of the consultation with Oshpod was that we probably won't gain much time in the schedule in terms of what your expectations are on the larger project.
All right. Thank you very much. Anything else that you'd like to add, Mr. Lorenz or Ms. Tullies? I know you're on the call as well.
Not at this time, Supervisor. This is Paul Lorenz.
Ms. Tullies?
Not at this time.
All right. Thank you very much. Then I think what I will do is simply ask for a motion from Supervisor Ellenberg to approve the recommended action, which at this point is simply to receive the report, unless we have speakers on the item. So let me first, forgive me, folks, check in with the clerk. Any speakers on this item?
We do, Mr. Chair. We have one speaker.
Please let that one speaker go, and then I will return to Supervisor Ellenberg. And again, a reminder to the speaker, we have set aside 2 minutes for comments today. Welcome.
Next speaker is Scott Largent. I am unmuting you. Please accept the unmute and you'll have 2 minutes to speak once the timer begins.
I can't sugarcoat my comments. This is Scott Largent. That place is just a dump, and I understand that we're tearing it all down and we're building another big shiny building, and this is not directed at facilities and fleet. I mean, there's only a certain amount they can do to shine that rusty penny up. You know, a pressure washer maybe, maybe some dignified signs rather than wrapping tarps around old things and old garbage cans and shoving cones in ways of doors, and the amount of black mold that is around that building right there, it's scary stuff. And I know you've moved the mental health urgent care for the time being over to the building to the side there. This is like just one flew over the cuckoo's nest. I'm not impressed with that place. I never have been. And, you know, many people probably won't really say this. I was a customer there. I went to that place for about 8 hours, and they had to cut me loose and get me out of there. But that place was horrid inside. And that's one place I would love to get a camera in. It's just sad. And I know we're going to tear it all down and something's going to be big and new. But at that point, the public won't be able to do what I'm doing right now. I went over there a couple of days ago, filmed out in front, and they sent the entire cavalry after me. Your deep cover, what do we call them, Santa Clara County fake cops that Jeff Smith has put in place to make them look like real law enforcement, they were all over me. Then they called the sheriff's department. I mean, all I was doing was filming people actually doing maintenance out in front. Let's get people up to speed. Let's let the public understand what's going on, and just, you guys can shine that place up a little bit before you tear it down. Thank you.
And I believe that was our only speaker. Let me confirm that with the clerk.
That's correct.
Thank you. Then if I can get a motion to receive the report.
So moved.
Thank you. I have, for the record, a motion by Supervisor Ellenberg, second by Supervisor Simidian. And the one last comment request I would make, and I'd ask all of the county staff who are involved with the project to lean in on what may seem a superficial issue, but I worked with the staff at the recent board meeting to make sure that we did not lose the reference to child and adolescent psychiatric services in the title for this project. And I want to ask that that remain front and center. I know that when I first brought this issue to our county staff through Ms. Tullies and through Dr. Smith, I was and I remain focused primarily on the adolescent psychiatric services and services for younger children. The staff indicated a greater need for a broader population, and we ended up with an even more ambitious project, and I think that's all to the good. But I want to make sure that we do not lose sight of the adolescent psychiatric services and inpatient child services that were, for me, the original catalyst. So I will want to keep driving that point home and make sure that that does not get lost in the larger, more ambitious effort. We're going to ask the clerk now to call the roll. We have a motion by Ellenberg and a second by Simidian. Please call the roll.
Vice Chairperson Ellenberg,
Yes.
Chairperson Simidian.
Simidian, aye. And the motion carries 2-0 on item number 5. That takes us to item number 6, which is the Public Health Officer's report. And Dr. Cody, I think I saw your square and face there earlier in the meeting. Can we ask you to present on this item, please?
Cody, Public Health Officer, and I will provide you a brief report of where we are with COVID-19 and the response, and a little update on the new health officer order, and be happy to answer any questions you might have. So just to start with the basic facts, as of yesterday at 5 o'clock, the county had recorded 2,134 confirmed COVID cases among county residents and 107 deaths. I want to just step back a little bit and put that in perspective, because I think the perspective is going to be helpful as we talk about the actions and rationale behind what we are now doing. I want you to remember back to early February when we had just 2 travel-associated cases and travelers returning from Wuhan. And I just looked back in my notes. As of February 4th, we had 2 of the 11 cases in the entire United States. So we were 18%. Santa Clara County was 18% in early February. And now, of course, we are less than 5% of the cases in the state, and a tiny, tiny, tiny fraction of the now 1 million+ cases in the country. So we did get an early start here in Santa Clara County. We now know with the medical examiner's detailed work that identified a death on February 7th as being COVID-19 in a resident of our county. We now know that we had community transmission that was occurring, must have been occurring at least by mid to late January. So we've been at this for a while, but what I really want to emphasize is that it's the gradual steps that our community has taken, and most recently the sheltering in place that everyone has done with significant sacrifice on the part of people, family, and businesses. It's worked. It's really worked. So what we see in our county and in our region is we have flattened the curve. We have certainly protected our hospital capacity. And now going forward, we want to maintain the progress that we've made. We do not want to in any way squander that enormous effort that everyone has already put into place. So before I talk a little bit more about the new shelter-in-place order that will be going into effect on Monday, I wanted to just briefly touch on, and I remind you all of the many of the big bodies of work that are going on here in the Emergency Operations Center to address COVID-19. And this is just part, by no means all. We still have a number of, a large scope of work is our hospital surge group looking to work with hospitals, understand their needs, provide guidance, and protect capacity. We have our entire public health branch, which is something of a reformulation of what used to be our Medical Health Joint Operations Center. They're performing surveillance, case and contact investigation, and a lot of special investigations and care and feeding of particularly vulnerable groups, particularly those living in skilled nursing facilities or long-term care, or other congregate settings such as homeless shelters, or following up on outbreaks in the community to try to break chains of transmission. Lots of work going on there. Of course, all of the housing work done. And then we have quite an operation to aggregate all of the data that we have so that we can track the outbreak and understand the impact of what we're doing. So I have been asked, why extend the shelter in place? Why are we doing this? We've made such great progress. Our hospitals are in good shape. Why do we need to keep doing this? And the answer is, one, we need to protect the progress that we've made. We need to not slip back. We need to protect the hospital capacity that we've created. And we need to keep our case numbers low. And we have a really important opportunity right now. Our case numbers are such that we, with very aggressive testing, case investigation, and contact tracing, we have an opportunity to begin to pivot towards a more focused approach where we identify and interrupt as many chains of transmission as we can. We are by no means there, which is why we need to keep this very protective shelter in place around us as we try to pivot to a more focused approach. At the same time, we understand that sheltering in place, while it has demonstrated to be very protective as far as COVID-19, it has been enormously disruptive to the economy and to the social fabric, and those have health impacts as well. So we're trying to navigate this path very gingerly with these trade-offs, trying to choose what is overall most health protective for our community, and doing so in what continues to be a rapidly changing environment where there's new information nearly every day. I wanted to highlight, talk a little bit about the indicators that we will be following so that we understand as we gradually, we've eased some of the restrictions of the shelter in place a little bit, and we need to follow very closely to understand how they are impacting the case counts and the transmission of COVID-19. But before I do that, I just wanted to highlight, for example, new things that we know that we didn't understand as well when we implemented the shelter in place. And I think top on that list is the degree of asymptomatic transmission. So that is, early on, we just didn't know. I think we talked about this at early health and hospital committee meetings. There were so much basic information about this new coronavirus that we didn't know. Things like what's the incubation period, and how long is someone infectious, and what's the level, can someone spread the infection if they don't have symptoms, or how long before symptoms might someone be able to spread the infection, et cetera, et cetera. Some of those questions remain unanswered, but for some, we're beginning to get a much better idea. And most importantly, we now understand that the degree of transmission that occurs from people who have no symptoms at all appears to be rather significant. And estimates range widely from as little as 25% to as much as 75 to 80%. I don't know what the correct number is. I just know that it's a lot. And when you have that level of asymptomatic transmission, that means that the strategy needs to be very different. So the shelter-in-place strategy is a pretty good one when you have a lot of asymptomatic transmission, but of course, it's not a very focused strategy. And in order to move to that focused strategy, what's important is testing to identify people who might be infectious, and then the infrastructure in place to ensure that they can safely isolate for the period of time that they might be able to spread the infection, as well as being able to follow and even test contacts to ensure that those contacts who have been exposed don't also become cases that might be infectious. So quite a large body of work. So in collaboration with the health officers across the Bay Area region, we developed a number of indicators to help us track where we are and what progress we're making. I want to highlight that these indicators are important for us to track and important for us to track along with members of the public so we all understand where we are. But as with everything in COVID-19, they will be necessary but not sufficient, and we may need to adjust and add as we go forward and learn more. To touch on those indicators just a little bit, the first indicator is that the total number of cases in the community, we want to see that they're either flat or decreasing, as well as the number of hospitalizations of patients with COVID-19. We want to see that flat or decreasing. Of course, we do understand that as we do more testing, we will identify more cases. And so we expect to see the case counts actually go up as we do more testing. But then as we begin to saturate, we should again see them hopefully flat or decreasing. The number of hospitalized patients is a more stable indicator because it's fairly stable over time, but it's a lagging indicator. It usually takes at least 14 days for hospitalizations to reflect what transmission is actually occurring in the community. So it's stable but lagging, and not so good for being nimble in our decision making. Second indicator is we need to ensure that we have sufficient hospital capacity to meet the needs of our residents. And I think we are doing an excellent job there in our county. The third indicator is sufficient COVID-19 viral detection tests are being conducted each day. We have a dashboard on our website, so you can see how many tests are conducted in the county each day, as well as the % of those that are positive. I just wanted to highlight, we are looking at, this is for the viral detection test or the PCR test. So this is not the antibody tests. Antibody tests are coming online, but the science regarding them is, and how to interpret them is still in flux. So when we're talking about testing, what we're talking about is the PCR test. The fourth indicator is that we have sufficient case investigation, contact tracing, and isolation quarantine capacity. And this is not just the people to interview cases and to get the contacts and trace the contacts. This is a massive body of work, because it's no good to reach a case unless you can also ensure that that case can safely isolate for the period of time that they're infectious. And so for many of our residents, that may mean that they need support with housing, with food, with income replacement, with care of family members. Many levels of support may be necessary to ensure that they can isolate for the duration of time that they're infectious. And similarly, we, of course, will endeavor to reach all of their contacts, but we also need to ensure that all of the contacts who may become infectious during that period can also safely quarantine for the duration of time that they may develop symptoms, which is 14 days. And that may also require support as far as food, housing, or other support. I was talking about having this window of opportunity since we have been successful in flattening the curve. And so, for example, when we interview a case now, most people with infection don't have that many contacts because they've been sheltering at home. And so it's a smaller scope of work. as we go forward, people will have more contacts, and that will, of course, be a much larger body of work. And finally, the fifth indicator is around personal protective equipment. The indicator is that we have at least a 30-day supply of PPE available for all healthcare providers. And we thought together as a region about ways to measure each of these indicators. Some we actually are already meeting, and some we're we'll have quite a bit of work to do. And not just in the public sector, but really across all sectors. This is, as with everything in the COVID-19 response, it's really a all hands on deck. So I think I will pause there and answer any questions or take the conversation where you may wish.
Thank you very much, Dr. Cody. And before we go to comments and questions, what I want to do is go to Dr. Smith, see if he has anything he would like to offer to supplement your report, then go, excuse me, to members of the public who may wish to speak on this item and who are queued up, and I'll ask the clerk to assist in that. And then Supervisor Ellenberg, you and I will have the chance to weigh in with comments or questions, okay? So Dr. Smith, anything you'd like to add at this point?
Thank you, Mr. President, or Chairperson, sorry. There have been a number of questions about the PCR test and the capacity in the county. So I just wanted to give the committee a bit of an update on capacity issues. Within the county delivery system, that being VMC, O'Connor, St. Louis, we have 4 sites that are in the outpatient world where we're collecting specimens. One is at the DePaul Clinic, one is at the East Valley Clinic, one is at the downtown clinic, and one is in Milpitas. And we're working on finding another site farther north. There had been the possibility of using Sunnyvale, but it's not quite set up to be able to collect the specimens. But once the specimens are collected, they're then sent to the central lab in the VMC basement. Those tests are done along with tests that are ordered from the inpatients in all 3 hospitals and the emergency room patients in any of the hospitals where the test is ordered. We currently have the capacity to do about 300 tests a day. That's not collecting samples, that's providing results. We're having problems with getting reagent, and we're hopeful that within the next 2 to 3 weeks we'll get sufficient reagent in order to bump our capacity up to 1,300 a day. The reagent is difficult to obtain worldwide, and that's because, as Dr. Cody pointed out, there are a number of different types of PCR tests made by different laboratories, and they all use slightly different reagents. Not all, but most of them use slightly different reagents, so they're in short supply. In addition to what we do in our delivery system, we also have the public health lab, separate lab over on VMC's campus, where we can do another 40 a day, in addition to what I just said. And then we have other private entities and governmental entities in the county. We're doing testing. Stanford is doing testing. I understand their capacity is somewhere in the 100 per day range at this point. We have the state standing up additional sites. They haven't actually been cited in our county yet, but they have contracted with a group called OptumServe, and they're putting up statewide sites where they're going to be staffing them completely and doing all the security and testing. I understand that the test will actually be run by Quest Labs, and the governor has the intent to be able to do 60 to 80,000 tests a day. So that would mean our number would be somewhere in the 4,000 a day, the goal. And then in addition to that, we have at the fairgrounds, Verily setting up, or they've already set up a collection station. And also in the San Jose area, they were working on a site. I'm not sure that it's actually set up at this point, but everybody is doing their best to increase the amount of testing so that we can meet the targets, as Dr. Cody pointed out.
Thank you for that, Dr. Smith. You've anticipated, of course, the fact that both Supervisor Ellenberg and I are likely to have some comments and questions on testing, and I suspect we'll hear some public comment on that as well. So thank you for anticipating that. Let me turn to the clerk and ask how many folks we have queued up to speak under item number 6, comment.
We currently have 4 speakers in queue.
I'm sorry, to the clerk's office, I lost you there. Could you repeat that, please?
We currently have 4 speakers in the queue.
Thank you. Then let's give just one more minute for anyone else to join the queue. But after the first speaker, I am going to cut it off and say, however many are in the queue, that is what we've got. So in order to manage our time effectively, we will allow 2 minutes. So we'll ask you to go ahead and start with the first speaker. And if that speaker would identify themselves, or if you want to do that for us from the clerk's office, that is just fine. Go right ahead.
The next speaker is Robert Aguirre. I am unmuting you. Please accept the unmute, and you will have 2 minutes to speak once the time.
And forgive me, Mr. Clerk, but we are not hearing anything, at least not at my end.
Okay, we'll go on to the next speaker.
Thank
The
you.
next speaker is Heidi Owens. I'm unmuting you. Please accept the unmute, and you'll have 2 minutes to speak once the timer begins.
Hi, Dr. Cody. I'm a huge fan and deeply appreciative of your compassionate and courageous leadership. I'm seeing a number of posts on Facebook pushing back against the continuation of the shelter-in-place order. They mostly center on 2 topics. One is the loss of personal liberty, and the second is a number of pseudoscientific arguments for why we don't need to continue the shelter-in-place. Can you please provide a 1 or 2 sentence quote that I can make into a meme to combat the misinformation and whining?
Dr. Cody, I'm going to circle back to you after we get done with public comment. So if the speaker will just hang in there for a bit, Dr. Cody will have a chance to weigh in if she chooses to do so in a little bit. Anything else, Ms. Owens, at this time?
No, that's it. Thank you.
Thank you so much. And our next speaker, please.
Our next speaker is Scott Lodgen. Scott, we're going to unmute you. Once we unmute you, you will have 2 minutes to talk.
Thank you, Scott Largent. Hopefully when Robert Aguirre was on earlier, and I understand he wasn't able to speak, technical difficulties, hopefully we'll allow him to chime in again. My concern right now is we've only tested 200 people that are living on the streets right now. I know there's more people on the streets that are sick right now. I know areas and locations where they are sick. I know you're releasing inmates from the Santa Clara County Jail that do have COVID. I know we're not getting the whole truth. And it's not letting the cat out of the bag, but you guys are very aware that I've been talking to people for the last 4.5 years of my sobriety. So the people you talk to, work with, your inner circle has started to become my inner circle. And I appreciate these people letting me know what's going on. The most alarming one was now, and I could be totally wrong about this, from a higher ranking San Jose police officer. He let me know that there's 3 or 4 more police officers from the PD that have COVID. And because they live in a different county, you're not reporting it properly. That is shady in my book right there. And because they weren't technically on the job when they got it, or were utilizing the secondary employment unit, that's why they're not reporting it. And they're trying to dodge liability of these officers getting sick. Now, could I be wrong? The other gentleman that led law enforcement on a high-speed chase that stole 24 cars, I got a little birdie told me that that guy had COVID. And that's why they released him on the side of the freeway and cited and released him when he fought with law enforcement. He was also released out of the Santa Clara County Jail. Now, if I'm wrong, let me know I'm wrong.
We're going to go back to Mr. Aguirre. Mr. Aguirre, I am unmuting you. Please accept the unmute. You will have 2 minutes to speak when the timer begins.
Hello, this is Robert Aguirre, and I would like to not only echo the concerns that Scott Largent just gave about the few number of people that are being tested that are unhoused, but also the lack of information of where the people that were tested and confirmed positive, where they were living at the time or where they were picked up from at that time, so that the people that are going out and trying to provide services to these people out in the streets, that we know what areas have been basically infected in one way or another, not only for our own safety, but for the safety of the other people that live in the area and people that come into those areas. And since people are living in the streets, they can't really shelter in place because they have no shelter, they have no place. But we can mark off areas where they are located and warn other people not to enter into that encampment because there's a possibility that they may become infected themselves. And since people can be asymptomatic, it is possible that there are people that are carriers of COVID-19, but or coronavirus, and they are unaware of it because there's no testing being done. So I urge you to please release the information of the locations of where the people were either living or where they were first picked up and maybe taken in for testing, so that other people can be aware of it, because this thing could spread just like it did when Wuhan was going on and they weren't releasing that information. And then because that information wasn't released, many, many other people have died, including my mother died from COVID-19. And I'm very concerned because there was no testing done of the people that she was living with, which is my brother, his wife, and their son. So please.
Our final speaker on this item is Liz Niss. I am unmuting you. Please accept the unmute, and you will have 2 minutes to speak when the timer begins. Ms. Niss, can you hear us? Mr. Chair, it seems we're not able to unmute Ms. Niss at the moment.
Can you put us back to our regular screen then for a moment, please?
Absolutely.
And I see Supervisor Niss. One moment, please. Supervisor Nisk, if you can hear the sound of my voice and you're not.
I've just unmuted myself.
There we go. All right, let's see if we can make this work. Mr. Clerk, for 2 minutes, please.
Thank you. Thanks for giving me a chance to speak. Thank you to Dr. Cody and so forth for all the work that you've been doing. I'm speaking to you today, not only as a council member from Palo Alto, but also on behalf of the association, the Cities Association of our county. You probably received a letter this morning, which I hope you have in your packet. Probably got it at places, as we usually say, which expresses our deep concern about testing. Without question, what we hear more than anything else is how important testing is from every angle, whether it's the governor, even the president is emphasizing testing. So, and what we've heard more than that even is not only is there testing, but then contact tracing, and on top of that, of course, treatment. So our question is, how do we, and I heard you, Dr. Smith, go into this, but how do we increase our testing even more? And especially at the north end of the county, we are more than willing to do whatever part we can do that is of assistance and also helps to up that number of testings being done. Here's our concern, and I heard the previous speaker say, you know, kind of, it's time to suck it up and stay home. And it's not difficult to stay home, but there are those of us who truly need to earn a living, and you can't do that sitting at home. So looking at us here in Palo Alto, at the north end, south end, the economy of this is what is really troubling. I don't want us to shortchange staying at home, but I want us to up the ante on testing, on reporting, and especially on looking long-term to how we can re-enter the workplace and do that safely. So I appreciate this. I hope that we will get some answers about further testing and that we can go from that lower number to a much higher one. Thank you so much, Supervisor Savidian.
Thank you, Ms. Niss. And let me just confirm with the clerk, I believe that is the last of our speakers on this item, yes?
That is correct, sir.
And I had to smile when Councilmember Niss said that she hoped that the letter was at our places because, of course, since we're participating virtually, we have no places. But I do want to just hold up the letter and indicate that not only did we receive it virtually, but that I have a hard copy in front of me as we carry on this conversation. Thank you to all of the speakers. And Ms. Ellenberg, what I'm going to do at this point, Supervisor, is offer some comments, then go to you for comments. Then I'm going to ask some questions, then go to you for questions. And I hope that works for you as we sort of break it out. Comments, comments, questions, questions. Can we make that work today?
Well, if you're super attached to that, I can try, but I have to say that my comments and questions are sort of interspersed.
All right. Well, then my only desire, Supervisor Ellenberg, was to get to you sooner rather than later, but I'll offer my comments and questions. It may take a little longer, and then I'll go to you for both comments and questions. I do understand that sometimes they're inexorably interwoven, so I take your point. Dr. Smith, you're still with us, yes?
I'm still here, yes.
Thank you. And Dr. Cody, you're with us as well, yes?
Yes, I am.
Thanks so much. I want to start with just 3 sort of bullet points because I want to make sure that in the conversation they don't get lost, and then offer some other comments as well, and then pursue a few questions as I indicated a minute ago. The 3 sort of essential bullet points that I want to lay down as a sort of basis for thinking about these issues today is that as we look at the 1 month ahead, we need to chart a path back to normal. So that's sort of point number 1. We need to chart a path back to normal. Point number 2 is it's time to test. And in fact, I would say it's past time. And point number 3 is we need a clearer method for community members who feel that they need a hearing to get themselves heard and to get a response. So again, I know there are a lot of folks out there scrambling, doing a lot of good work because I've been able to access the county resources to help deal with constituent inquiries. But I think as we have scrambled on this, there's more that we need to do to create a clearer method for community members who feel that they need a hearing to get themselves heard and to get a response. So that's the 1, 2, 3 of it for me. Charting the path back to normal, ramping up our testing in a really dramatic way, and sort of a clearer method for folks to access the system and get themselves heard. Now, just a few other comments before we get into the questions and how-tos. First, there was a press announcement on Monday that was essentially an announcement of the announcement that was coming. And I just say, and I mean this is the most constructive of criticisms, I don't think it was a particularly well-considered release. Both essentially announcing 48 hours ahead of time, we're going to come up with a new set of plans, but we aren't going to tell you what they are until Wednesday, and specifically the language that was used. I understand and am frankly quite sympathetic and impressed even the challenges that it must entail to work with 6, 7 different public health officers from counties and cities around the Bay Area. And I know we're trying to develop consensus, and I think that's been integral to the success of the effort. But just so people understand how this played out in the real world, what happened was the announcement went out on Monday saying, hey, we're about to issue a new order. That new order is going to be substantially similar to the order in place with very few accommodations. And so then what happened was everybody who thought that they had a right to some accommodation spent 48 hours working themselves up into a lather and expressing their anger because they were pretty sure, based on Monday's announcement, that they hadn't been heard over the last 6 weeks. In fact, the announcement today, I thought, did a very nice job of laying out case by case some of the accommodations that public health officials thought could and should be made, both with respect to construction, which is no small industry, childcare issues, which of course loom large, outdoor activities where we've had a lot of commentary. But again, just going forward, and that's why I'm not sharing any of this to be finger wagging. I'm sharing it because I hope as people talk in the future about how to share information, that there is an understanding that perhaps this didn't work out as well as intended in terms of giving the community a heads up about what was coming. Second thing is, and I actually, on a sort of a thumbs up basis, I do want to thank all those who involved, and notwithstanding the questions and concerns that were raised during the public comment, I think all of the information on the Public Health Department's webpage, and particularly the dashboards that have been referenced a couple of times, have really been doing a very good job of providing folks with the information they want and need to make informed decisions. And I've been particularly impressed by the fact that whenever there's a request for more information or someone expresses a concern or even an outright complaint, people have listened and have responded. And that is a resource that, in my observation, has gotten better and better and better with every passing day and every passing week. So thank you for that. Dr. Cody, I want to interrupt my own long riff here to ask you if you have any thoughts about the continued requests we get from some folks in the community, not all, for more location information that is more specific. I know there are some factors you weigh in making that judgment. Could you comment a little bit on that just for the record, please?
Thank you, Supervisor Simidian. As you know, now we have cases listed by city. We have a practice now twice a week of looking at our data, both to try to understand what it means, and then when we find something that we think is meaningful, to figure out how to best post it and keep it updated for the public. I hope that we will be able to present data as far as location in a more refined way. It's just as the race ethnicity data was challenging because we have a lot of missing data. Actually, the location data is a bit challenging because when you look at it by a number or by a rate or by a zip code or by a census tract, it sort of starts telling a different story, and it's difficult to know which storyline represents the truth.
If someone were to say to you, well, look, if there's an outbreak at a nursing home at 123 Main Street and there have been a dozen cases identified there, can't we, shouldn't we provide that information? What's your take on that, both in terms of the public health dimensions and the privacy requirements of state and federal law?
So I can't weigh in on the state or federal law. I know that at one point the state, I believe, was posting more detailed information regarding ill patients and staff on their website. I've not been on the website recently to go and look. I think that ideally, if a family member was in a nursing home and the family was speaking with a nursing home, the nursing home would make information available about the conditions there. That may or may not be the case. I do know with other communicable diseases, if we feel that there's an action that the person needs to take, we provide that information. So, and to be honest, I've not looked.
I can probably help with some of the issue related to quasi-legal issues. I don't think we have county counsel on the line, but
I'm here.
No, I see Mr. Press's.
Oh, there you are, Doug. My understanding is that, and Doug will fill me in if I'm wrong, but the issue of the reporting of location of nursing homes, the state has had a site up where they are reporting the number of patients and the number of staff that are infected in particular nursing homes. My understanding is there's been some debate about whether that violates the law in terms of confidentiality. And James is looking into it at this point. We do report congregate data on the webpage right now. Obviously, we'd prefer to report data by nursing home, and that's where most, a third of our cases come from nursing homes. Doug, did I get that even remotely correct?
Yes. Yeah, there's concern about obviously having identifiable, as you say, de-identified data. So that is a concern. I know that we, as a county counsel's office, we are still looking into it, but that does raise concerns certainly under federal law.
Well, let me make this a formal request then. And do I see Ms. Ellenberg raising her hand? I can't tell there. Yes, Ms. Ellenberg, are you trying to weigh in on this issue as well? I see the nod of the head. Thank you. I'll come
I am.
And hold that thought if you could for just a moment.
I could interrupt quickly.
Hang on just a moment, please. I do want to formally ask Mr. Press for a memo from the county counsel's office on what the law requires, prohibits, allows, and folded into such a memo it would be helpful if we had not just the legal analysis, but essentially the public health perspective about what is a sound public health practice in terms of information being shared, because there's an intersection here between both the legal side and the public health side. Thank you for your patience. To you, Ms. Ellenberg.
Sure. And I'm a little bit confused because I had this conversation earlier this week with council and with Doug that this information was fine, that we could list by facility, that was sufficiently de-identified, and that you would respond to my request to update the long-term care facility dashboard to show case counts by facility.
Yes. In a very nice way, let me just say that the issue boils down to, from the way it's been explained to me legally, is whether or not that listing the number of patients in a particular nursing home gives enough information to identify them. And of course, my argument back to county council is in an emergency situation, we have a balancing act argument. So without being a lawyer and not trying to put pressure on county council, I think we'll get there. It's a matter of wrestling the whole thing to the ground.
I hope you don't mean wrestling county council to the ground.
No.
My understanding had been that this was settled, and so I would conclude then that we are not currently on the way to updating the long-term care facility dashboard by facility, but in response to my colleague's request for a legal memo, hopefully we can get there very quickly and start publicly sharing that information.
What we have is we've got the data, and I've directed the IT staff to be prepared to put it up. But obviously, I want to get it blessed by county council first. And, we do have the problem legally of the state doing what you're requesting, but doing it intermittently. So, there's also the question of, well, how can the state do it? And how come we couldn't do it? But of course, we always defer legal decisions to county council because I just play a lawyer on TV.
Well,
As do I. Thank you for the indulging the interruption, Supervisor Simidian.
no, thank you, Supervisor. Very helpful, I think, so that Mr. Press and his colleagues in the County Council's office have a fuller understanding of what we're looking for. Mr. Press, I will just say, I think the question goes not just to congregate facilities, whether they are assisted living or skilled nursing facilities, but to, we've had folks requesting identification of hotspots by block, by street address. And as I say, I think there are a number of trade-offs there. It will not surprise anyone who's worked with me over the years to know I share the notion. I think Dr. Smith articulated that there's a balancing that has to occur here. And the balancing is the public's right to know with the right to privacy, particularly pursuant to HIPAA at the federal level, with the public health need for clear understanding and communication going forward. So all of those challenging issues will be blended, I hope, into any consideration we get from your office. And,
sure. And I would add,
go right ahead, please.
As part of the balance, of course, is the safety of the infected individuals and people suspected of infection. That also is part of the equation, as well as the fact that, as Dr. Cody has highlighted, that we still have asymptomatic transmission. So there's a number of different factors, which is why this is not a particularly simple question to answer, but we will get you that memo.
And Mr. Press, you were very tactful when you said the safety, but I assume by that you're referring to the potential adverse consequence of individual subsets of the community becoming targets for animosity or even violence. Is that part of what you're talking about there?
That is correct.
Thank you. I think it's a significant and legitimate concern. I just wanted to make sure we were explicit about all that. Dr. Smith, for you and others involved in what I'll call probably county council, but also others involved in the EOC, the Emergency Operations Center, I'll just say I'd like to work with you over the course of the next week to have a simpler answer. And that's what I meant by a clearer method for community members who feel they need a hearing to get themselves heard and to get a response. Is that something that you could work with me and my office on over the course of the next week?
Sure, we can do that. Right now, we do have online the question and answer connection, so they can email us a question or make their point. But as you point out, it requires the connection to the web, so we can certainly work on something more clear.
That has not actually, thank you for that. I'll work with you, and certainly we'll share with Supervisor Ellenberg and other members of the board whatever you all come up with. The issue of access was not really the issue that was concerning to me. I take this as sort of a backhanded compliment to the entire team, and I really do mean this. I think that you've been so vigorous about setting up ways for people to be in touch that it's almost a little bit confusing. And it would, to some extent, be easier if we could just say to people, this is the one place you can go and be sure that you will be heard and somebody will get back to you. So if, for example, that is the CBO email for community-based organizations, then the end, stop. But having this multiplicity of places, I think, has made it, I know the attempt is to make sure there's more than one way to get the issue addressed or resolved, but I think it has made it a little less clear for some folks, where do I go? And, part of this is, it's an unusual circumstance. We've got an order issued by the public health officer. And then the question is, well, what about this? What about that? Okay. And then when somebody says, I don't think I'm being treated fairly, where do they go? How do they make their case? So I know there are answers to that right now. And my point is, I'm hoping we could simplify that bundle of answers to a very quick, easy, here, sort of a no wrong door, but also how about just one door if we could possibly get there.
Like a task force, just saying.
I'm just going to go right by that.
just keep going.
Then on this issue of testing, and I don't know if Ms. Niss is still on the call with us or not, but I did want to indicate, because we are doing all this virtually, it is impressive to me that, first of all, I thought the letter was quite on point. So I am fundamentally sympathetic with the issues that are raised in the letter dated April 29th. I should also note that it is signed by literally every single mayor in Santa Clara County, all 15 of the 15 mayors. So I think that doesn't make anyone's argument right, but it does tell us that the arguments that are made in the letter and the requests and the concerns are widely shared throughout the county. Dr. Smith, as you went through the many testing opportunities, I couldn't help but think that for all that effort, if I look at the testing data on our dashboard, we're still talking in the relative hundreds of tests on a daily basis. So let's say it's 500. That, has been the ramp up after a month and a half, 2 months of inquiries and entreaties and expressions of concern about increasing our capacity. And we're still at a place where, and forgive me if I sound like I'm a half empty, not half full kind of guy today, but that represents 1/40th of 1% of our county population. And even if we got to that 60 to 80,000 number statewide, which, as you indicated, our pro rata share, my quick back of the envelope calculation is that means we could do one test for every member of the every resident of the county over the course of about a year and a half. So I'm mindful of the exhortation from the health officer, Dr. Cody, that first on her list of things we needed to move forward was a total count of the cases in the county. And then related to that, obviously, was her third item, which was the sufficient number of tests, the PCR tests. And at some point, we're going to need to have the antibody tests, in my layman's judgment, once we figure out what they do and don't tell us. But all of this is essential to moving forward. And the reason I make the point that it's essential to moving forward is that this is in my experience, a unique circumstance. We've talked about this before, which is our success in this effort rests quite heavily on the shoulders of the general public. And if the general public is persuaded that what they hear is authoritative and sound, then I think we can count on their continued engagement. I frankly have been, very impressed with the extent to which folks have said, all right, we're going to do our part. Scofflaws notwithstanding, I think anyone would have to assess the general compliance as extraordinarily high. But we're only going to be able to maintain that, particularly now that we are looking at another month, if people believe we are using the next month to chart that path forward that I referenced earlier. And we're not going to be able to do that unless we have the tests. So I'm not asking you today to snap your fingers or wave the magic wand, but I am saying that what I'd like to do, if Supervisor Ellenberg is agreeable, is to use this two-person health and hospital committee as essentially a de facto board committee to work with a staff member to be identified by you to tee up testing that is dramatically more robust than what we've seen today, or even the incremental improvements that have been suggested. I know Supervisor Niss, who preceded me and succeeded me as a representative of the North County, mentioned the concern in our area. I was gratified that Ed Shikata, the city manager of Palo Alto, reached out to me to express his interest and willingness in having the city play a role if they could be helpful. I talked with the CEO at El Camino Hospital in Mountain View, and of course they serve a wider region. And they've indicated not only their willingness to try and partner with us, but to provide physical space if need be to provide this. I think the fundamental challenge is no one has said that it's their responsibility to get the testing done. Not the federal government, not the state government, not county government, not city government. So if I ask the question, whose responsibility is this? More often than not, there's a long pause. So I think at this point, while I think there's reason to be encouraged by Governor Newsom's efforts at the state level, what we need to do is step up and say, we're going to take the initiative to see what we can do to dramatically increase the number of tests. So why don't I stop there and ask you, is that something that, and we'll see where Supervisor Ellenberg is, but I'm remembering her many comments about testing over the past couple of months as well. Is that something, Dr. Smith, we could try and pivot our attention to now that things are only in crisis mode 23 hours a day as opposed to 25 hours a day?
Well, first of all, this has from the very beginning been a priority, but it's also a priority that we have very little control over locally. The shortages of reagents, the fact that the FDA and the CDC and CMS have to approve the tests, the fact that the CDC tests initially were ineffective has all put us behind the 8 ball. And then we have many parts of the country that are doing much worse than we are. So they're sucking up the capacity. But that being said, we all realize that we need to do some more, that see what we can do to get more tests. Kaiser has been able to get tests. I think it would be a great idea, as you mentioned, for us to work with El Camino. We've been working with Stanford. We've also been working with Quest and Verily. But anything we can do to increase the number of tests available would be a good idea. So I can definitely identify somebody in the EOC who can work with you and Supervisor Ellenberg to get that done.
Well, thank you. And I'm going to try and take my own advice, which is to take yes for an answer. But I do want to say, I think, Supervisor Ellenberg, I went back and watched our committee meetings from January and February and March. I noted that both you and I have been raising this concern about testing for quite some time now. I raised it at the March 10th meeting of our board, which was the first time our full board met, in my recollection, to talk about it. And I think, it's not, Dr. Smith, it's not that I disagree with you about having control, but I think it's pretty clear at this point that if we wait for somebody who, quote, has control to show up on our doorstep and start offering tests in some great number, we could be waiting a while, because 2 months later, we're still in much the same place I know for public health purposes that the incremental growth in testing that we've been able to achieve has significance, but in terms of charting a course back, these numbers are pretty modest. That's the kindest way I can put it. And even if we were, quote, not successful because these things were beyond our control, if all we did was raise hell from top to bottom of the system so that folks who had the ability to make progress in this area felt a little more impetus to do so, then I think that is a productive and necessary effort. So I will, after we hear from Supervisor Ellenberg, and I'm going to turn to her in just a moment, I will circle back to you to close out this conversation. And I certainly want to hear from Dr. Cody if she has thoughts about this, but I'm turning to Dr.
I address this point before you move on to other
Yes,
issues.
I'm going to get to you, and I'm going to really stop for a good long time. But what I wanted to just make sure is I certainly want to hear from Dr. Cody before we wrap all this up, if she has thoughts she'd like to share. But I'm going to Dr. Smith on this one in particular, because I think this is really an operational issue where he's probably the right person to talk to, but I do not want to preclude Dr. Cody. The end for now. Turning to you, Supervisor Ellenberg, and thank you for your patience. And I'm going to Supervisor Ellenberg to be clear for both comments and questions. Thank you.
Got it. Let me start with just a direct response. You asked for my opinion or input on not repurposing, but adding another focus to this committee. And I want to say, number one, that yes, I have been asking for this for months. The reason that I put forth the referral at our last board meeting asking for a detailed report on where we are in moving toward all of these important indicators, not only testing, but PPE and contact tracing and all of the other benchmarks that we've been talking about. We absolutely have to have a specific and detailed plan, and I will weave that into my questions. And Dr. Smith comments that this isn't in our control, and I will agree to that partially. However, there is such a discrepancy in what's happening from state to state and county to county that I fully believe that there is more that we could be and must be doing to move this along. So yes, I am certainly in support of that, as I am in support of having a streamlined, centralized process that affords members of the community direct access and opportunity to ask questions of either Dr. Cody herself or more realistically members of the public health department. And I think now more than ever, now that we are starting to look at reopening various sectors, the questions are going to be coming fast and furious. So a method to handle that would certainly be of great help. Let me go back to the beginning now of the notes that I had created based on the agenda. And let me start by thanking, because it can't be done enough, Dr. Cody and your team and all of the folks in public health and in the EOS for continuing to plug away at a mammoth crisis in which we are still in the midst. I appreciated the focus of today's press conference on talking about setting clear targets on the indicators that we've been discussing over the last month around testing, contact tracing, health system capacity, and case counts. However, I want to be sure that we need to go a little bit further. We need firm, quantifiable targets to reopen and transparent data on our current progress. This is critical to our oversight, mine and my colleagues as supervisors, and to the public understanding and trust in our response. And since we are expecting people to continue to make sacrifices, at least through the end of May, we really need to be clear about the targets, and we need to demonstrate that we are doing everything we can to meet them as fast as possible. So with that in mind, I'm going to drill down a little bit on each of the indicators that were mentioned, and then I have some general questions to follow up on today's press conference about the expansion. Dr. Smith noted that we are, well, from the data dashboard, it looks like we're doing about 1,000 tests per day. And Dr. Smith, you noted that our target is 4,000 a day. Is that an official minimum required to open us even further, or is that just mathematically the local proportion of the state goal?
That
I
question
can
is
answer that.
yeah, that's
Right.
Sarah's question.
Yeah.
Thanks, Dr. Cody.
Sure. So just in general, with regards to indicators, our region has worked very hard to try to develop indicators that are measurable and also that we can measure in all jurisdictions so we can see how we're doing as a region. And we will each endeavor to post it so you all can see. So we actually have thought through those details. With regards to the lab indicator, it is around tests done because we each have a dashboard where you can see that. The number 4,000 roughly equates to around 2 per 1,000 per day per population. We were looking at a number of different sources and trying to triangulate and get to that number. That's the one that we came up with, but I will say that it may not be robust enough. So it's the indicator that we have developed collaboratively across the region that seems to be in alignment with the numbers that the state is coming up with and other academics are coming up with, but it may be, the bar may not be high enough.
Okay, thank you. And then that would certainly reemphasize the necessity of building that number as quickly as we can. Both Robert Aguirre and Scott Largent mentioned the data that we've administered just 200 tests to unhoused residents who are living in shelters and perhaps unhoused as well, a population which is clearly at particularly high risk. What are we doing to address the testing gap there in shelters and in other congregate living settings, as well as out in the open for the fully unhoused population?
I'm sorry, I was interrupted during your question in the EOC, but I think your question was around testing in vulnerable populations, congregate shelters, and other high-risk settings.
Correct, and the fact that we've only administered 200 total to date.
No, that's we in all of our most vulnerable populations, skilled nursing facilities, long-term care facilities, homeless shelters, jails, or community outbreaks. I don't have a number, but it's vastly
My
more
number,
than that.
the 200 number, Dr. Cody, was specifically for unhoused residents, not the aggregate of vulnerable populations.
Okay, I don't know whether I don't know the exact number. What I do know and what I can tell you is that an entire body of work is dedicated to ensuring that people who are unhoused or unstably housed and who have COVID-19 get housed, and that those who have symptoms do get tested. And there's been a lot of collaboration and outreach to ensure that. I don't have the numbers,
Sure.
but we could get back to you.
Well, the number is in the report, and my question, I understand and truly appreciate that everyone that's tested positive has been able to be moved into shelter. The question that I'm getting at is, are we testing sufficiently? Might there not be a far higher percentage of what would be positive cases if we were testing more broadly, specifically in the unhoused population? And if we are under testing and therefore contributing to a broader spread of the disease, is that not something that we should be addressing?
Maybe I can jump in on that, because it's really not public health that's doing the testing. It's VMC and the supportive housing team and the homeless team at the health system. And, you know, obviously we would like to test a lot more. It's a challenging endeavor because it's an uncomfortable test in a population that's very reluctant to take care. But that being said, it is something that we have a team working on, trying to develop new techniques, new strategies to get them tested. What we can say now is that everyone who has tested positive in the unhoused population has a either an apartment or hotel room or another way to isolate. But I agree completely, we should have more, and it's really a matter of trying to get as many tests as we can and get identifying data for the individuals that are unhoused. So yes, it's critically important.
Okay, well, clearly we have a theme here, and let me correct myself, and to Dr. Cody, the 200 number is actually not from the public health department, it's from a San Jose Inside article, so I apologize for attributing perhaps greater weight to that than may be warranted. Let me move on to a question about contact tracing. How many staff members do we currently have working on contact tracing? And as the need will grow for this work, as we prepare to reopen, what tools and strategies are being mobilized now to begin to meet that need?
So at the moment, the model that we have is we have public health staff that are doing both case investigation and contact tracing. They are, our team is collaborating very closely actually with San Francisco. Both of us are also using an application to assist with the contact tracing and with communicating with contacts after they've been identified. San Francisco Department of Public Health, in collaboration with UCSF, has also developed a training program, and all of these resources are being shared, which is wonderful. But right now, we are currently staffed with Public Health Department staff for both the case and contact investigations. We are bringing online this application, and we are, this is our short-term plan, but we are looking to pivot longer term to a model that we can sustain over the long term, and because we know that this epidemic is going to last for a long time. And we may need to, depending on how the epidemic looks, either dramatically expand or contract the staff needed to accomplish the task. And I also, I really cannot emphasize this enough. It is not just the staff who are doing the case and contact investigations. It is no good to identify a case if they can't isolate and if you can't break the chain of transmission. And it is no good to identify a contact if that contact cannot quarantine. So the whole, connecting to community resources is absolutely critical to our success.
Great.
Here's the interruption, Supervisor Elbert. I did want to say, Dr. Cody, my recollection from our last board meeting was that when I asked the question about how many folks it would take in Santa Clara County to do the kind of contact tracing we're talking about, that while you were not yet able to give us a definitive answer, that it was probably in the hundreds. Am I remembering that correctly?
Yes, you are.
Thank you. Excuse the interruption, Supervisor Ellenberg.
No problem. You'll see that I submitted a referral this afternoon that's asking administration to consider whether it might be useful to partner with any of our community-based organizations that already do not contact tracing, but on the ground in community work, if it turns out that we do need an expanded workforce beyond the capacity of our county employees. So that's just another piece in thinking about how we might be rallying more support and more partners for this work. With regard to hospital capacity, the VMC—
Can I jump in a little
Please.
bit on the case
Sure.
testing? Sorry, my fingers was slow. To try to give the committee some concept of numbers, you saw that Governor Cuomo in New York is saying that he thinks they need 30 people per 100,000. So that would be somewhere in the region of 600 people for us. And I think Sarah hit on, the problems with that in terms of it's not sufficient just to have the bodies, but they also have to be trained. They have to be connected to the services, and they have to be willing to stay on it for a year or 2 years, because as Supervisor Simidian pointed out, it's going to take a while for us to be able to test every one of the 2 million individuals that we have living in our community. So we will certainly respond to your referral, and I think, in sum, the response will be, yeah, we need to work with them, and we will definitely do it. But we'll have a more complex response for you.
Terrific. With regard to hospital capacity, the VMC report today indicates that they have good capacity to meet demands and even some level of surge. Thank you, Paul, for that report. Does someone here know if that's the case across the other hospitals in the county other than our 3?
I can jump in on that. Yes, our dashboard does show that they all have surge capacity. The one that is having problems with their COVID patients, it's not impacting, at least according to their numbers, the surge capacity, but it is impacting their discharge abilities, is Regional Hospital, which has our highest percentage of COVID patients as inpatients, but a significant portion of them could be discharged to other facilities, lower acuity facilities, if we had more lower acuity facilities willing to take COVID patients. As you're aware,
Isn't that what the FRC is for?
The FRC is a respite area, so if they can be cared for in the FRC, yes, we're sending them to the FRC. But what I'm talking about is people who need more than just respite care. They need skilled nursing facility care, and the skilled nursing facilities are under no obligation to take them if they don't want them. The other thing I should say about the FRC is the state is thinking about redeploying parts of it to different locations. They will still leave at least a significant portion of it, but the FRC in Santa Clara is the only FRC in the state that actually has patients in it.
You're right, and my understanding is very few patients with plenty of capacity to add if needed.
Right. And I think the state, again, this is all being organized through Cal OES. And the state considers all the FRCs to be regional assets. And what they're trying to do is figure out how to get more patients from surrounding areas into the FRC, which obviously we support and would like to see too, because you don't want to waste that resource. So we're working with them, trying to help them out to do that.
Okay, thank you. I'm going to move to PPE as another indicator. How is the EOC assessing overall capacity for PPE? To break that down a little bit, are targets set by the type of item or by facility? And I'm getting mixed messages from various sources and different types of organizations about our ability to source PPE. So let me start with that question. How are we counting and organizing?
I think I'll try to answer that too, unless Sarah, you wanted to jump in on something, but I can think I can do it. In the EOC, we have a team that's dedicated to collecting data. You remember one of the last orders that was given required everybody in the county to give us a list of what PPE they had. And we've had pretty good response with some significant numbers. So we have a team that's collecting that, led by staff from VMC. They're correlating all of that along with trying to purchase PPE from vendors and also requesting PPE from the state and the feds. You're right, it's the availability of different components of the PPE is different. The most challenging right now is the N95 masks because they're disposable and many of them are used every day. About 30,000 countywide at least are used every day. The other challenging resource is cappers, which are sort of helmets that are used in acute care and operating scenario. They cover the entire face, and they have a respirator that goes out the back of the equipment. Those are challenging to find also. We're also having troubles with medical grade gowns because the gowns are required to be made of special cloth that can breathe, but also are not permeable to liquids. But we have plenty of gloves, and there are other PPEs that are used in the construction and hazmat area that are more challenging to find. But we at the EOC coordinate requests from other agencies and hospitals and skilled nursing facilities. And at this point, we're keeping up, but we're very clear that we don't have access to enough to spend 30,000 a day for a long period of time. But we're trying to get it from everywhere we can.
So there's the question. We know what our burn rate is, and we know that right now we have enough. I think I read or heard for about 3 weeks. But how do we know when we have met the indicator? How do we know, for purposes of moving into different phases of this, that we have a sufficient supply? Is it a formula of burn rate times the number of days, and as soon as we can say we've got that in hand, that we are ready to move to a new phase?
I think that's
I can answer that, Supervisor. For our indicator, we're asking, because as Dr. Smith outlined, it's very complex, the amount of PPE and the types of PPE in hospitals. What we're asking as an indicator is for hospitals to certify in writing to the health officer that they have access to supply. And the reason why is because some hospitals are part of larger systems where they don't keep a supply on hand. They get it from their hospital group, and others need to keep the supply on hand. So we didn't want to have an indicator that talked about supply on hand because it comes in different ways. Secondly, we also have another indicator around facilities not needing to make a PPE request to the Emergency Operations Center to use our cache. So that's the way we're going to measure it. And this was, again, after extensive discussion with our colleagues around the Bay Area.
Do we not have a kind of an emergency ruling in place where even if they don't typically measure or count them or keep track this way, that we need them to do that right now?
So as Dr. Smith mentioned, we have 2 health officer orders in place in our county. The first order mandates that hospitals report their PPE, and there's a very detailed list of PPE that they need to report, and they need to do that daily, and skilled nursing facilities do that weekly. So we have actually a much more detailed and up-to-date sense of PPE availability in our county as compared to other jurisdictions.
I see. Okay, thank you. Case counts is the last indicator that you mentioned. And while our case counts are growing more slowly, which is wonderful news, I am particularly concerned about the case counts in the skilled nursing facilities. Supervisor Simitian touched on this a little bit during his comments, concerning both for the higher risk of severe illness of the patients and the overall impact on local case counts. And it looks like over the past 2 to 3 days, more than 40% of our new cases were tied in some way to skilled nursing facilities. How can we look at the trajectory of community case counts separately from the skilled nursing cases? And I understand that they're listed separately on dashboards, but to really look at the seriousness and the degree of spread across the community, separating out the skilled nursing facility numbers.
Yes, we actually do separate them out, and it is a great concern. Anytime COVID-19 is introduced into a facility, it really does spread like wildfire, and it's very, very, very dangerous. So not only do skilled nursing facility patients represent a disproportionate number of the cases, but they're certainly representing a significant proportion of the deaths. I haven't calculated it recently. So to your point, preventing introduction of COVID into skilled nursing facilities and controlling those outbreaks when they occur is really, really, really important, and will have an impact on our overall case counts. It's extraordinarily challenging, and we have done everything from deploy infection control staff to the skilled nursing facilities, to pulling other nursing staff to work in facilities when they're short-staffed because staff are out ill, et cetera, et cetera. So we're beginning to see some bend, but it's extraordinarily challenging.
Sure.
I wanted to just step back and talk a little bit about. I wanted to make sure that I emphasize this as we do more testing, and it's, as everyone knows, critical that this get going fast. It cannot go fast enough. We will find more cases, and so our case counts will go up, but our positivity rate should go down. So it may be at times a little bit difficult to interpret. When you look at the number of new cases per day, when you sort of take the average and look at it now, it's not that different than it looked when we put the original shelter-in-place order into effect in mid-March. And I want to emphasize that point, because what that means is if we completely lifted everything and just went about our business, we would see exponential growth, as has been seen in communities that I've either have implemented shelter in place late or have lifted it too soon.
Yeah, it will be interesting to see what happens across the country in the next couple of weeks. Going to shift again. One question about in a later item in your public health report, Dr. Cody, you talk about some youth engagement activities, and I want to connect that here to see what your thoughts and your department's thoughts are, particularly around teenagers and masks. And I support your decision to have kept the language concerning the wearing of masks to be strongly encouraged when people are out in public, out in the community. I think we have a particularly tough population with younger and older teens, and I'm wondering if there has been any thought around PSAs that involve that are made by teens for teens, any other kind of interactive, well, interactive is the wrong word, proactive messaging or engagement so that we can really emphasize to this population who largely, I'm led to understand, is going to be either somewhat immune to the virus or less likely to be hit as severely themselves. How do you suggest that we really step up our ability to convey the seriousness and really encourage compliance, not only with the masks, but with the social distancing rules, particularly as the weather gets warmer and whatever's left of the school year formally ends?
Let me try to jump in and do this one because this has to do with our PIO team and the way that we've been responding to communicating with the public. We've been doing PSAs that have been focused pretty much on the entire gamut of the impact of the disease and the questions of about the order. But we haven't, as you know, focused exclusively on the youth up until now. And I think it's clearly a good idea to do that with youth communicating directly with other youth. And so we do have a team and we've hired staff. And so I will communicate that to them as a next step. I'm sure they're probably some of them thinking about it, but I'll make sure that they do it.
Okay. And to wrap up my questions about the indicators, just to clarify from the order that was announced today, is the intent that each of the Bay Area counties would revise their orders on different timeframes as each one meets the 5 indicators that are outlined?
So the 5 indicators are out as outlined are indicators that we have coalesced around together that are aligned with what we understand the state will be tracking to get us all sort of moving in the same direction in the same way.
What if we are much more successful than another county and we have met them and we are raring to go, but San Mateo or there's no reason for me to name anybody else, but another county isn't there yet. Do we wait for them?
Right. I think we will probably all be meeting different indicators at different times. But the reason that we did this as a regional effort is we know that that we really are one region, and the epidemic tends to go as a block, not county by county. And so that is why we have taken the strategy since early on is that we're moving together as a region. So I think it will just, what I can commit is that we each in our counties are looking at them frequently, as well as discussing in our group frequently as we develop them and as we watch them.
Right.
So I don't have a definitive answer to your question.
Right. I know that seems to be the norm these days, and it's frustrating, and I understand all at once. Given the indicators and the efforts that we've been talking about for the last hour plus to continue to scale resources, just reminding Dr. Smith that the board approved my referral at the last meeting to lay out in as much specificity as possible the response needs and resources that are needed to achieve those targets. And I'm looking forward to seeing that report.
Yes. We do have that on the next agenda. And well, no, I guess it's on the agenda after that, the 12th.
Perfect.
I just found out from the PIO team who was listening that indeed they've been working with community partners to get youth to youth PSAs lined up. So they've already
I'm glad to hear that. Thank you, PIO team, for that quick response. I want to turn now to thinking about the impact of the state and local orders on our residents. And as are many, I'm increasingly concerned that these orders are disproportionately impacting our lower income workers, small employers, sole proprietors, and tradespeople, many of whom are already living under the strain of high housing prices and higher cost of living. And certainly none of us wants to see COVID-19 push these residents out of our community. In light of Governor Newsom's announcement yesterday on phases for reopening schools and businesses, and the updates, of course, announced in our county today, I want to be sure that we as a county are supporting businesses, organizations, and families in putting those orders into practice. So I want us to be thinking about how we are planning to engage these sectors of our community and working through future phases of the response and orders, in particular, again, with a focus on small businesses, employers, houses of worship, childcare providers that may not have the resources to adapt their organizations, and certainly particularly concerned about the disproportionate impact on communities of color and small operations that might not have the technology to shift online and pick up and shift their business model. I was glad to hear today that it's your view that many outdoor industry sectors will be able to open after Monday, subject to social distancing protocols specific to whatever the nature is of their work. I'd like to ask why eating food at restaurants with outdoor seating, appropriate spacing, and other protocols are falling into a different category than the obvious of construction, which also is happening outside. Was there thought given to that, and is there something that you can tell the public and that I can explain to help understand why outdoor eating has not been included in this first category?
So a couple basic principles. One is that we, as I've mentioned before, wanted to proceed very gingerly. While we are delighted at the progress we've made, we don't want to squander everyone's collective sacrifice. And so we wanted to go very slowly. When we describe outdoor businesses, we're thinking about outdoor businesses that were outdoor businesses before the shelter-in-place order went into effect. In other words, not that you could change your business to an outdoor business. And with regards to outdoor cafes and bars, they're not completely outdoors. It's a combination of indoors and outdoors. It's not completely outdoors, and it would have to be to maintain the social distancing of 6 feet is a minimum. So you have to think about duration and time, as well as the workers and the kind of contact that the workers need to have with each other. And so it just did not add up to us to feel, for us to feel as comfortable with the transmission risks, at least not for this first step.
Okay. I think we're going to kind of brace to hear a lot about that. President or Chair Smitty, and I see you're leaning in, and I've just got one more topic and question to ask, 2 questions, but same topic, and this is about childcare. I understand that today's local order allows some additional childcare camps and school activities with stable groups smaller than 12. I'm really pleased about that. It's very much in line with issues that I've been raising about ensuring that any phased reopening looks at the needs of parents and families in conjunction with reopening. We've been doing that here at the county with essential workers, and that has been working well, with much appreciation to Leslie Crowell and the many partners working on that. But as other businesses begin to open, how will we sort through the various state and local orders to assure that as people get ready to go back to work, that they have safe and accessible options for childcare?
Thank you for the question. I want to highlight that the changes to this order, of course, is to expand it to think about summer camps and other educational and recreational institutions as for all children. But it's still only if the parents of those children are working in essential businesses or government functions, or now outdoor businesses, et cetera. So it's expanded, but not completely. And I don't, our county council has been, working to really understand the state order and how that matches up with our local order. we're really emphasizing that whichever order is more strict is the order that prevails. My guess is that as we kind of inch along and iterate, that will expand.
So let me just play that out a little bit to make sure that I understand it and can explain it clearly. In order for a parent to enroll their child in a program, they have to demonstrate that they are working in a business that has now reopened up in connection with your order. Is that correct?
That's correct. So essential businesses, and now the essential business has expanded, now includes contractors, essential governmental functions,
right.
Outdoor businesses, that's a new category, or working in some minimum basic operations. So those folks, because they need to work, then the children, as long as they're in the stable groups of 12, can participate in these activities.
So if I'm a parent working from home or have lost my job and am not working, I can't send my kid to a camp program.
Not yet.
Okay. And then on the flip side of that, what providers will be allowed to open? Will private camp and summer enrichment programs be able to declare on their own they're going to open and they'll accept kids consistent with this order? Or will particular summer programs be given specific leave to open up and begin their programs?
It's really, I think it's really going to be up to the programs to consider whether that model will fit. So it's any childcare establishment, summer camp, or other educational or recreational institution. So they would need to be able to, be able to provide their program in these small stable groups that don't change, which, for example, for a lot of, summer camps are usually structured where you have a different group of kids every week. It's not a small stable group over time.
Okay, but essentially the kids that sign up for that program will be, I don't want to say police, but overseen, or there's some kind of county level enforcement of this that would ensure that a summer program isn't opening up to serve a group of kids whose families will, have the means to pay for this and are going to put their kids in a 6-week summer program, and that specific activity would not be permitted under the current shelter in place, under the new rule.
Yeah.
Correct?
Right. I would, to be honest, I defer to colleagues in county council and law enforcement who are assisting with the implementation and are better poised to answer that particular question.
Right, I can jump in a little bit. The enforcement of the orders is up to local jurisdictions, basically the police and the DA, and county council has the option to do a civil enforcement, but public health, neither public health nor EOC will be doing enforcement. It'll be local jurisdictions and those that I mentioned.
I'll tell you, and I can take it up in another venue with county council, but to me that's extremely troubling, because if the protocols are met, if the groups are the same, if they're small, if all of the social distancing pieces are in place, and there's space available, it's harder to make an argument that a parent couldn't choose to send their child there, particularly in the scope of the private providers. It's going to become a lot more complicated.
Right. Everything about sheltering in place is extraordinarily complicated. I still want to get back to the overarching goal, which is that we, to the greatest extent possible, continue to shelter in place and bring case counts down as we pivot. So every extra activity, business, et cetera, increases the probability of transmission because it's increasing the number of contacts that we have with each other. So
Right.
it's still quite limited.
I'm going to leave it for now, but I think that there's going to be more to, I know that there will be more to talk about and work through on this. I think it's going to become, as you correctly note, Dr. Cody, more and more complicated as we start to open some and not others, allow some and not others, in a way that I think will be critical, that does not feel arbitrary, and that's what's going to get harder and harder. But I'll leave it there now. I realize we've got a lot of agenda ahead of us. Thank you.
Thank you. One last issue, and I want to pull Mr. Press into this, and or anyone else from the County Counsel's office who's on the line with us, and that is, I think, Mr. Press, I want to make what I think is an accurate statement and have you fact check me on it. And because I've been, as you might imagine, approached by a number of constituents who say you should do this, you should do that. And what I have told them is, in some cases I might agree, some cases I might not, but that we are in a situation where the County Board of Supervisors, both collectively and certainly any individual supervisor, is not under state law in a position to provide either direction or or overrule the public health officer. Is that an accurate statement?
Yes, the health officer is the definitive, what would be the word, voice on public health matters in the county.
And presumably, just for the record, I've asked, just yesterday, I've asked Mr. Williams to give us a memo on this matter, because as I mentioned at a prior board meeting, I do think a clear understanding of roles and responsibilities is going to be helpful and important. And I think candidly unfair to Dr. Cody and her team for the weight of the world on all these decisions to rest on their shoulders when her work is public health and not so much some of these operational issues that are now inexorably interwoven with her bailiwick. But Mr. Press, presumably that's the case for some limited period of time. Is it only when the public health emergency is in force and effect? Yes, no? Is it forever? And if the answer is don't know, need to get back to you, that's a perfectly understandable answer.
Yeah, I would say a public health emergency has been declared, but I do, rather than speculate, I do want to investigate as to essentially how does this terminate? Who decides when a public health emergency is over? Is that your question?
Well, yes, and I mean, I could imagine, based on the information that Dr. Cody has provided us, that we are in a public health emergency, or certainly in a difficult circumstance in terms of public health considerations for not just weeks, but months. Dr. Cody, does that seem possible?
Absolutely.
So then, Mr. Press, then the question is, does that mean that Dr. Cody and her team are going to have to be responsible for determining who can play golf and at what hours and under what circumstances? Ms. Ellenberg got into great detail, and I say that as a compliment, Ms. Ellenberg, about, well, what about this and what about that, and you could see it quickly becomes a bit of an enforcement morass. So I'm trying to figure out at what point do we let go of what pieces of all this, and at what point and for what functions does the Board of Supervisors have responsibility? And so, the request I've already made to Mr. Williams, and again, just yesterday, but I wanted to bring this up today as much as we could, is a function of making sure that we're all doing our jobs, but we can't all be doing our jobs if we don't know what they are. And as I've said before, there's a fine line between interference and oversight. I think we obviously have an obligation to provide oversight. On the other hand, I think we've seen at other levels of government what happens when elected officials interfere rather than provide oversight. So back to you, Mr. Press. You know, my question is sort of who's responsible for what and at what point, and is the only way to change the dynamic to say there isn't a public health emergency when there's likely to be a public health emergency for quite some time.
And Doug, before you answer that, I just want to tie this back to what we were talking about earlier in terms of how businesses, childcare, other sectors will work on implementation of these orders, addressing all of these questions. Mine certainly barely touched the surface. And if it's not the supervisors, and I agree that it's not, making the call and the decisions here, again, we need some kind of centralized direct access process, venue, hearing structure to be able to vet these questions, answer them, hear proposals and suggestions, and be able to implement successfully and safely.
Yeah, just a couple of things. One, I can say that I know that the folks in the Emergency Operations Center and I personally have fielded a number of calls from members of the community and public about questions about enforcement of the orders as they have evolved. I've also been advised by Mr. Williams, as Supervisor Smitty has pointed out, that this query is presently being processed by the County Council's office. So I don't want to preempt the folks in the EOC who are presently formulating an answer, but I'm relaying with Mr. Williams in real time on this very issue.
All right. I think I'll let this go with a to be continued, Mr. Press, but I think you can see from just this brief conversation how quickly we get to a very difficult set of trade-offs along these lines. Supervisor Ellenberg, unless there's anything else, I want to just close as I had indicated I would at the outset of this conversation, with thanks, of course, to everybody who's just, scrambling day after day after day after day. But by saying once again what I said at the opening, which is I really do think we need to chart a path back to normal, and that community compliance will only be forthcoming in the next month if people are very clear that we are using this time well and wisely to chart that path. So it's not just, as Supervisor Ellenberg has alluded to, the right thing to do and a necessity. It's also, frankly, essential if we're going to continue to engage the cooperation of the public, who I think for the most part has done an extraordinary job and deserves a shout out and some thanks as well today. I also want to reiterate the importance of testing. I said at the front end, it's time to test. I think it's past time to test. I appreciate Dr. Smith's candor about some of the limitations that may be there, but I think we have to look at those as challenges to be overcome, not impediments that we simply accept. And finally, as I said, we do need a clearer method for community members who feel like they need to get a hearing. And again, lots of folks have spent a lot of time responding to a lot of inquiries. So I don't want to suggest otherwise for a moment, but I do want to say if we can simplify that for folks so they know where to go and how to get their questions addressed or their concerns addressed if they feel that they've been misjudged, that'll be helpful and important. With that, Supervisor Ellenberg, unless you've got anything else, it would be appropriate to take a motion to receive the report of the public health officer.
So moved.
And I'm going to second that. Before I call for a roll call, Dr. Cody, want to make sure we give you the last word today if there's anything else you'd like to share.
So thank you for the opportunity. And I wholeheartedly agree with your 3 points. And I also wholeheartedly agree that it's the collective work of the public that has gotten us to where we are. And I think we are all grateful.
All right. All right,
Thank
then
you.
without objection, we'll ask the clerk to call the roll on this item, which is simply to receive the report after all of that. And I apologize if the clerk is calling the roll. I cannot hear it. Could we ask you to try one more time?
Vice Chairperson Ellenberg
Yes.
and Chairperson Simidian.
Simidian, aye.
Thank you.
Then the motion carries 2-0. And I think at this point, in fairness and kindness to all parties concerned, if there's no objection, I'm going to ask for a 5-minute break, Supervisor Ellenberg, if that's agreeable to you. I'm getting a thumbs up, and we will reconvene. We'll keep the lines open, obviously, but we will reconvene in 5 minutes, which will be 4:35. Thank you all so much. All right, folks, we are going to reconvene this meeting of the Health and Hospital Committee for the Santa Clara County Board of Supervisors. We took a 5-minute recess at 4:30, and it is now 4:35 or just past. We had completed item number 6, which was the report of the Public Health Officer in connection with COVID-19, almost exclusively today. And that takes us to item number 7, which is to receive the report from Custody Health Services relating to COVID-19 and the measures being taken to prevent the spread of the virus that causes COVID-19. Let me just ask if all parties are back on the line, who's presenting on this item? Let me turn to the clerk and or to other staff who can introduce themselves.
Supervisor Simitian, this is Andrew James, the Interim Director of Custody Health Services. I will be presenting.
Thank you so much, Mr. James. Go right ahead.
Thank you, Supervisor. Ladies and gentlemen, we have done taken several measures to prevent and control the COVID-19 crisis. I will begin by explaining how we are protecting the employees. So employees who can carry out their duties at home via telecommuting have been instructed to do so. All employees have been instructed not to come to work if they have any symptoms or they have been exposed to an infected individual until they've been completely cleared by employee health. Symptoms checks, including a temperature reading, are conducted before employees can enter the workplace. Employees with symptoms are sent home. Disinfectants, gloves, hand sanitizers are available to employees at their work locations, such as booking, behavioral health services, nursing stations, etc. And surgical masks are available to all staff for use in patient care and non-patient care areas within correctional facilities. Personal protective equipment, N95 masks, isolation gowns, and eye protection are also available to staff who are working in the units where COVID-19 or persons under investigations are housed. We have also made it required for all employees to use surgical masks in all patient and non-patient care areas where they cannot maintain 6 feet distance. It's required right now for them to wear these masks. Soap and water are available to all employees where there's a sink installed. The measures to protect inmates, we perform symptom checks for every inmate who enters the facility through booking. Inmates who fail the screening process are immediately masked and isolated for further assessment. If a patient is determined to be exposed, then he or she is immediately transferred to an isolation negative air pressure room for 14 days quarantine. Newly admitted inmates are temporarily housed in designated risk management housing units. And these are the non-COVID or PUI patients. These are just regular folks who have passed the screening. And they're kept in these risk management units for 14 days. And after the 14-day period, they are allowed to enter the facility's general population. If any inmate reports symptoms or is observed with symptoms, then the inmate is immediately masked and isolated in a designated COVID-19 management unit for further assessment. Inmates under COVID-19 investigation or those who are confirmed are isolated in single cells with negative air pressure and airborne precautions, and they're provided the necessary medical treatment if need be. All inmates have been issued cloth masks, and they are encouraged to wear them when they're in close proximity with other inmates or staff. And inmates with suicide risk or respiratory infection are provided a surgical mask to wear. They can exchange these masks as necessary. COVID-19 or PUI inmates are provided a surgical mask and gloves to wear when they're outside of their isolation housing unit. Soap and water are available to all inmates in the housing locations, and they're encouraged to wash their hands frequently and maintain good hand hygiene. We are also focusing a lot on social distancing, and in spite of a significant reduction in the jail population, which has created space for remaining inmates. Additional steps have been taken to maintain 6 feet separation, especially during pill calls, diabetes calls, sick calls. Inmates are instructed to remain 6 feet apart from each other. And if they cannot do so, then they are to come one at a time to see the nurse. Tape markings have been placed to maintain inmates 6 feet apart in all potentially crowded areas. And programming such as group therapy, which can cause crowding, has been suspended until further notice. Measures to prevent unnecessary contact, people who are self-serving any of the food items, that has been suspended. Food now arrives in boxes, which limits exposure. General visitation has been suspended until further notice. And there is limited and only necessary transfer of inmates between housing units. And all routine clinic appointments have been suspended. Only urgent and emergent visits continue. But inmates are screened for COVID-19 symptoms before coming to the appointment, and they're requested asked to wear a surgical mask before they arrive into the clinic. Additional measures to increase sanitation by custody, health, janitorial, and trustee staffs. All phones are disinfected between use, and all high contact surfaces such as counters, chairs, doorknobs are all disinfected at least twice a shift. And all reusable equipment such as blood pressure cuffs are disinfected between use. In addition, we have partnered up with our enterprise partners to manage the crisis. We have daily huddles with VMC Enterprise Hospital Command Center to stay informed about the hospital capacity, policies, and also to inform the Command Center leadership about custody health, COVID positive and PUI patients, our workflows, and our policies that we have implemented here. We also have a daily huddle with custody staff to discuss processes and policies that we have implemented, such as staff screening, social distancing, and use of masks in patient care area, and to discuss and design solutions to issues as they arise. We have posted signs everywhere that inform staff about the symptoms, if they have a fever, cough, shortness of breath, to notify medical staff. In addition, we've also posted signs about social distancing and not to have any unnecessary physical contact, and also to wash their hands frequently. And thank you. That concludes my report, Supervisor.
Forgive me, I hit unmute. Thank you, Mr. James. I'm going to turn to Supervisor Ellenberg and ask if she'd like to begin on this one. If not, I'm happy to go ahead. But given the fact that I took the lead on the last one, I thought I would share the opportunity, Supervisor, if you'd like to begin.
I appreciate that. Do we have public speakers that you'd like to hear first, or do you want to hear from me first?
Thank you for that reminder. Let me check with the clerk.
No speakers at the moment.
Thank you very much.
Oh,
Ms.
Thank you, and thank you for that report, Andrew. It's nice to get to start to work with you on this. You mentioned that inmates who are on suicide watch are given masks, and I'm curious and concerned about why those don't present some kind of physical danger. I imagine that someone could be creative in how to misuse a mask if they felt so motivated.
Yes, Supervisor Ellenberg, thank you for that question. Inmates on suicide watch whose clothes are removed and they're placed in an anti-suicide smock,
right,
which is commonly known as the Ferguson suit.
Yeah,
they're not given any masks. We don't give them any masks at all. But those who are on 15-minute checks, we provide a surgical mask, which is made out of sort of a thicker paper. It's breathable, and it has the small elastic ear loops. So those.
I'm sorry, I'm having a little trouble hearing you. You said it has elastics?
It has elastic ear loops, and those individuals, because they already have their clothing, so the rationale for that is, if they're going to harm themselves, they can harm themselves with their clothing.
Sure, I had thought you said that patients that were on suicide watch, assuming then that they didn't have clothing or other items.
Yeah, if their clothing has been removed and they have a Ferguson gown on, those individuals,
then they don't have a mask. Okay, thanks.
Yes,
thank you. I have just a couple of brief questions that I imagine will have similarly brief answers. What supports is Custody Health providing to the county's youth correctional facilities for COVID-19 prevention or response?
So we provide all the support that we provide for adults to juvenile hall and youth facilities as well. So whether it's related to screening process, whether it's related to social distancing, putting up signs, or anything that we do in the adult setting, we're also doing that for the youth as well.
Again, you're a little bit in and out. I'm not sure if you're
so we're providing
moving away from your mic.
Can you hear me now?
Yes, thank you so much.
Yeah, so whatever full support we provide in the adult settings, we are also providing in the youth. Whether it's related to the screening process, whether it's PPE, whether it's providing masks for the youth, whether it's having one of these high-risk units where as new youth kids come in, they are placed over there for 14 days and monitored closely before they go. So whatever we're doing in the adult settings, we're also doing.
Is mirrored.
Yeah.
Okay,
it's
good.
mirrored, yes.
Thank you. Are there any plans to do surveillance testing of the jail populations for the virus among asymptomatic inmates?
Yes, we are in communication with VMC Command Center, and we are exploring that testing those individuals who are asymptomatic and increasing our testing. Yes.
Thank you. I want to extend appreciation for the hard work that has to have gone in to prevent any kind of significant outbreak in any of our custody settings. I know that a tremendous amount of work has gone into keeping that very vulnerable population safe. And my last question is really just asking you for a reflection, given what's happening in other custody settings in California and across the US. Are you seeing any best practices or areas of focus that are being implemented from what worked or didn't work in other jurisdictions? We seem to be doing well, but are there things we should be doing better?
Yes, so we have looked at CDCR, and we also looked at Shasta County Sheriff. They were the first ones to publish. And primarily, I think our best practices or our processes, protocols mirror theirs. And, we have definitely learned from them to, how to overemphasize on the social distancing and put the markers and all that. So we have adopted some practices from them, which is definitely related to social distancing.
Great. Thank you very much. That's all I'm going to ask right now.
Thank you.
Thank you, Supervisor Nollenberg. Mr. James, a couple of questions from me, if I may, please. One is, how are chain of command issues addressed in a setting like this where we've got a public health officer who's got certain orders that are of record? You, of course, represent custody health. But then, as you mentioned, you've got folks you're working with who are part of the corrections staff, who presumably take their direction from the independently elected sheriff. So could you share a little bit about how the chain of command works on these kinds of issues when you're in a setting with lots of different folks who are providing guidance?
Yes, sir. So primarily we partner up with VMC Command Center, and we follow the enterprise guidance to adhere to the chain of command that we are following. And we are following the public health department chain of command as far as the guidance that's coming out. As far as the custody staff, we are partnering with them and ensuring that we understand whatever the protocols that we are implementing, they're on board with us. And so we're just trying to work those out with them. And so far, it's been working really well, the partnership between custody health services and custody. But generally, we are under the public health guidelines.
But to be clear, a correctional officer, for example, is under no compunction to take direction from you or anyone else who's not part of the correctional officers / sheriff's department staff. Is that correct?
Yes, as far as taking direct directions, no, but what we do is we try to work with the leaders, and we share our best practices, and then have them actually give directives to their staff.
So then, understanding that attempt at working collaboratively and cooperatively, how has compliance been in terms of the direction provided, which cannot be directly mandated as a matter of chain of command?
Well, right now, I think it's more of strong recommendations that are coming from the custody leaders. And, it's basically, they're following the staff are following their chain of command right now.
What you're being exceptionally tactful, and I appreciate that, Mr. James. But what I'm trying to find out is, on any given day, if there are 100 folks who are custody officials, how many of them are in full compliance with the strong recommendations that have been provided about how to keep folks safe, including themselves?
I don't have a good answer for that right now, Supervisor. I would say.
I can jump in. Let me jump in here. Supervisor, great questions. We therefore asked our public health department to go over and audit the compliance with public health orders, basically the use of PPE and the social distancing and the treatment of inmates as well as employees. And the public health audit team found that they were very compliant and were doing a great job. And as a matter of fact, the sheriffs set up a internal team themselves to assure compliance and tracing with all of their custodial employees as well as with their patrol employees. And so they've gotten a red star saying that, or gold star, I should say, from the evaluation, and they've been doing a great job and the cooperation has been good. So even though we could get into arguments about who's in control, we have not, and they've been complying well.
Good to hear, of course. My next question is for either Mr. James or Dr. Smith or anyone else on the staff who's appropriate. So if we had an unfortunate mass outbreak of COVID in the jail, what's the plan? How do we deal with that?
Right. So for that, Supervisor Smedian, we have a cohorting. We have units that are dedicated where we would actually house the COVID positive patients. We have several units dedicated in the main jail and also in Elmwood and in the juvenile hall. And we also are taking CDC guidelines and public health guidelines where we can actually cohort individuals who test positive. So we can use multiple cells where you have multiple beds instead of using up all the isolation cells. So that is the plan at the moment.
And how many inmates could that accommodate theoretically at the maximum?
I would say theoretically, so we have, I would say at least 500.
Okay, thank you. Thank you. And then forgive me if I just missed it, but I was not clear on whether or not the inmates are only offered the masks or whether it is required.
They are all offered the masks. They're all offered.
And what's the judgment about why it is not, quote, required?
We are requiring them in certain areas, such as clinical care areas. If they come to the clinics, they're all required. But if they go to their housing unit and the barracks, then obviously, it's up to custody staff to have them required. But we strongly encourage everybody to wear a mask, especially within close proximity.
You used the phrase barracks, which calls to mind during the most recent tour I had of the jail. We do have settings where there are 20 odd people essentially in bunk beds sharing the same space. Am I remembering that correctly, Mr. James?
Yes, sir.
And that's relatively close proximity. Am I remembering that correctly?
That is correct.
And we've got a bunch of folks in that setting who are encouraged but not required to wear their masks, which I understand, they're not comfortable, they're not pleasant, nobody likes them. I get that. So I understand that doing more than encouraging them represents a challenge. I'm just trying to assess the public health risk here.
Yes, they are still, in the barracks, they are strongly encouraged and advised to wear masks whenever they're in close proximity. And whenever we do rounds, we always encourage them to put on their masks when they are walking close to each other or associating with each other to make sure that other people are safe and they're safe.
And would you assess observationally, is that half, more than half, less than half who take you up on that good advice?
I would say it's more than half. I mean, most inmate patients, they're really they're conscientious and they do wear masks when they're walking around.
Okay. I forgive me for doing a deep dive in a fairly obscure issue, but do inmates have enough soap?
Yes, sir, they do.
My recollection is that they had to buy bar soap at one point, but that they got sort of small slivers of soap for daily cleanup. Am I remembering that right, or has that process changed?
I believe there was a supply chain issue, but those have been resolved. So there's plenty of soap right now.
All right. Then I'll just say thank you for your work. The one other observation I would make is I would hope that it's obvious that we have a responsibility for the health and well-being of both folks who are in custody as well as for our own employees. But I think it is perhaps not always as obvious to people that focusing on this seemingly small, isolated group of folks also has broader implications for public health, because at some point, folks are going to walk out of the jail and be part of the general population again. And if we send them out in a way that's unhealthy for all of us. So it's not just an employee and inmate issue. It's a matter of general importance to the broader population. Supervisor Ellenberg, unless you have other questions or comments, I would gratefully entertain a motion to receive the report on item number 7.
So moved.
And I will second, and I'll ask the clerk to formally call the roll, even though I think the outcome's pretty clear.
Thank you, Supervisor.
Mr. Chair, would you like to hear from the three public commenters in queue?
I did not realize we had 3. I thought we asked earlier, but I gather that they have queued up since. Is that what happened?
That's correct.
Great, then let's hear from all 3 of them, but we'll call it quits after those 3 who have already queued up. And let's walk through them one by one by one. Go right ahead. 2 minutes.
Understood. Thank you. The next speaker is Scott Largent. I am unmuting you. Please accept the unmute and you'll have 2 minutes to speak.
Thank you, everyone. Scott Largent. Phone's about ready to die, so you might not have to listen to me for the whole 2 minutes. I am concerned that people might be, well, I know they are being released from our jail that are sick. That I guess I'm just a little confused right now. I understand bail has been reduced to 0, and we've cleared out the population of our jail big time. But do these people really have a place to go when you're releasing them from jail? And if they are sick, that's a concern I have. And it's the same concern I have with the homeless population. We've only tested 200 out of 10,000. Are we testing these inmates? When we let them out that front door, and I've talked about this at supervisor meetings, they just start raising hell. They make it down near the FAA thing, which is now the new jungle. It's like Lord of the Flies over there. Great videos I've been putting together at that place. We need to get on top of that. And I'm just worried about it. I've been staying down there. It's not fun. I finally got out of the area there. Field trip time. How about that? Field trip time. Hop in a van, hop in your car, drive over there and take a look. These inmates get out right out that door and they go down the road. And are they sick? And what happens when they start hanging out in all these homeless encampments? That's just my concern. So thank you.
Thank you. And our next speaker.
The next speaker is Lorraine Zeller. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak once the timer begins. Hello, Lorraine. Okay, we'll go with the next. The next speaker is Dolores Alvarado. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak once the timer begins.
Hello?
Yes, we can.
Yeah, sorry, okay. My request is for item 8.
All right, this is Supervisor Simidian. We'll say thank you to Ms. Alvarado. We'll take her up when we get to item 8. Then meanwhile, we had one other person who had requested the opportunity to speak. I believe the first name was Lorraine. Let me ask the clerk if we can give them one more try just to make sure we don't overlook them if we can possibly avoid it.
Lorraine Zeller, I am unmuting you. Please accept the unmute and you'll have 2 minutes to speak once the timer begins.
Hi, yes, I'm Lorraine Zeller, a mental health advocate, and I'm also a retiring mental health peer support worker. And I'm very impressed with the report on custody health protections for the workers and the people in custody. But I don't see similar request for a report on the welfare and protections put in place for patients and workers at psychiatric inpatient units such as EPS and BAP and the IMDs. So I would like to ask that you request a report so we can all be clear on what's being done for these people as well. Thank you.
This is Supervisor Simidian saying thank you for the comment. And I believe under item 9C, when we received the verbal report from the Director of Behavioral Health Services, we can take that opportunity to make just such a request. I see Ms. Tully's is still up on our screen, so we'll give her a little bit of a heads up that that's a question likely to come her way when we get to item 9C. Thank you. I believe that means we have now heard from all of the folks who are queued up for item number 7. Is that correct? Looking to the clerk for confirmation.
That's correct.
And you have a motion to receive the report from Supervisor Ellenberg and a second from me. So let me ask the clerk at this point if you, I believe we have a motion. Yes, still, thank you. I'm seeing a confirming head nod from my colleague. So we'll ask the clerk to please call the roll.
Vice Chairperson Ellenberg.
Yes.
Chairperson Simidian.
Simidian, aye. Thank you. The item is approved for the record. That does take us now to item number 8, which is to receive the report from the County of Santa Clara's health system relating to community-based health clinics. And let me ask again, first for a staff report, then we'll go to members of the public who wish to speak. And we know we have at least one already queued up. So from a staff perspective, who's going to present on this item? I see Mr. Santiago leaning in. Does that mean we are looking to you, sir?
Yes, and good afternoon, Mr. Chair and Supervisor Ellenberg. We have for you the report. This is a request from you to report every 6 months on the status of the clinics. For convenience and point of reference, we divided the report in terms of pre-COVID, when clinics, quite frankly, were doing tremendous progress in terms of achieving their targets. We took a different approach this year based on your guidance to be more collaborative. And so we work very closely with them to not only get an assessment of their capacities, but also what they felt would be their particular targets related to each of the programs. Of course, during COVID, they've been just as acutely and severely impacted in terms of their capacities as we have as a health system. So things have changed, of course, subsequent beginning in March. So in many cases, we'll give you a general summary here, but in many cases, they lost up to 60% of the capacities to serve the communities. Although I must recognize them for being very creative and adapting. Many of them have testing on a limited basis, but nonetheless, they do have testing. They've all implemented screening measures and procedures, as well as they continue to collaborate with our EOC in terms of the challenges that we're all grappling with in terms of the availability of materials and equipment, and obviously in terms of their continued service to the community. Post-COVID, we're looking, of course, at a brave new world, and that we still yet to understand fully. But we do anticipate engaging on a strategic planning process that you guide us in terms of engaging them. In the meantime, one of the things that we've been working very closely is to not only make sure that they get access to their fair share of the federal assistance that's available at the federal government through the various stimulus packages, but then also that they maintain and sustain their teams, because one of the things we're very concerned about is to make sure that we don't lose capacity in terms of serving the high-risk populations, particularly with whole person care. And so we continue to work with both the federal and state governments to make sure that we advocate for flexibility and direct funding for our FQHCs here, as well as our health system. That concludes my report, and I'm open in case you have any questions.
Thank you. Supervisor Ellenberg, I think before you or I weigh in, might be good to see if we have folks who are queued up to speak on this item. Yes?
Of course.
Thank you. Then we'll ask the clerk, do we have folks who want to speak on this item?
Yes, we have 2 people in queue currently.
All right, let me just ask before we go to those 2 people, if anyone else is out there who would like to be in the queue, we ask that you connect with us now so that we have a sense of that, because I will at some point, just as an administrative matter, need to sort of cut it off and say back to our board members. So if you want to be heard in addition to the 2 who are already queued up, please make your presence known as soon as you possibly can. All right, thank you. We'll go back to the clerk and let the clerk bring forward the folks who are going to speak on this item.
The next speaker is Luisa Boada. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak once the timer begins.
Okay, you can hear me now?
Yes, we can. Thank you, Ms. Boada.
Hi, good afternoon. Thank you for allowing the opportunity to speak and come before you on this item. As Mr. Santiago said, we are working with you to make sure that we keep essential services at the community level and keep our patients out of the emergency room. One of the challenges that we have is while we are connecting with whole person care patients, we are unable to enroll new whole person care patients or PCAP patients, which means that we won't be able to meet our targets. So we're hoping that you allow us to be kept whole for our contracts for this year, even though we in terms of reimbursement, even though we have not been able to meet our targets fully. We also hope that you will allow us to begin to enroll electronically new whole person care and PCAP clients who we are discovering in the community need those services. And also, just as the county recognized that a lot of people are challenged financially, particularly in this time, but even before so because of the cost of living, that there really is a need to increase the PCAP level of eligibility for federal poverty level from 200% now to at least 300, but 300 to 350% would be ideal. And that would allow, some of the folks are being disqualified for just $1 over 200% of federal poverty. And it seems crazy when they're so challenged financially and so in need of these healthcare services. So we hope you would consider these requests, and thank you for the opportunity this afternoon.
Thank you. And Ms. Boada, before you step away, 2 things. First, Supervisor Ellenberg, I'm not sure if you're familiar with the Ravenswood clinics but they have stepped up at a very difficult time when our Mayview clinics really could not make a go of it after 47 years of service to the North County in Sunnyvale, Mountain View, and Palo Alto. So I want to say thank you to Ravenswood for their acquisition and continued service. Ms. Boada, if you're still on the line, could I ask you, could you kind of give me a bullet point, literally just 3 or 4 words, a reminder of what the asks were that you just made? Because I want to make sure, as people express their sort of more generalized anxiety, that I have the 1, 2, 3 of it, if there is a 1, 2, 3 of it. So could I ask you to go back and just give me the headlines, if you will, for each of those items?
Yeah, so the headlines are to keep the contract for whole person care whole, even though we are unable to meet the targets at this point in time, that we increase the PCAP level of federal level of poverty to 300 to 350% of poverty. And the last item is that we are able to enroll new whole person care and PCAP clients that we find electronically. We're doing renewals electronically, but we'd like to do the new clients that we encounter electronically as well.
Thank you. That's a very helpful and crisp summation, and I appreciate it. All right, I believe we have someone else on the line as well. Yes?
Yes, that is correct. The next speaker is Raimundo Espinosa. I am unmuting you. Please accept the unmute, and you'll have 2 minutes to speak once the timer begins.
Thank you so much.
Hello?
There you are. We hear you loud and clear, Mr. Espinosa. Go right
Okay,
ahead.
good. Thank you so much. This is Raimundo Espinosa with Gardner Health Services. I want to just echo what Luisa said, and first of all, thank you for making the opportunity to allow us to speak on this matter, Supervisor Ellenberg and Supervisor Semidian. First, I want to thank the staff, Renee and Alice, for allowing us to change the contract and make it better. Again, that was pre-COVID. Right now, I just want to echo the same remarks that Luisa said, and that is, if you could allow us to maximize the contract for both all WPC, GPP, and WPC PCAP, WPC, and GPP. I think that would go a long way to helping us try to maintain as much infrastructure as possible. Some of the issues that we're facing, for example, in our shop, we see about 9,000 dental individuals, 37,000 visits, and that went down 85% in March. Optometry went down 85%. Our medical went down to 70%. And so we've had to make some staffing adjustments, but in order to continue to maintain the staffing levels that we have, we would appreciate you taking that into consideration. With regards to the PCAP program, because people don't want to come in, we're focusing on renewals, but we're down about 40%. Not only because people don't want to come in, but we're avoiding the food banks, going to the school districts, going and doing outreach that way.
And Mr. Chair, my apologies. We have one more speaker, the speaker that started speaking in the previous item. And I believe you're muted, Mr. Chair.
Forgive me, I was asking, is Dolores Sandoval still in the queue somewhere?
Yes, we have Miss Dolores Alvarado. The next speaker is Dolores Alvarado. I am unmuting you. Please accept the unmute, and you will have 2 minutes to speak once the timer begins.
Forgive me for conflating two Doloreses there, Ms. Alvarado. My apologies. Go right ahead.
Thank you very much, Mr. Semidian. Not a problem. So I'm sorry Raimundo was not able to finish, but I know we will have more time to speak to both your staff and Supervisor Ellenberg's staff at their convenience, because we do want to share what we're doing at the clinic level what we're doing around specimen collection, testing arrangements, our work with VMC, our work with Dr. Karen Smith, since she came on in potentially helping her create a community planning testing program. So I do want to share that. That will take a long time. So one piece that I'd like to add to what Luisa and Raimundo said so eloquently is a reminder and request for Dr. Smith, Renee, the health plans. We had initiated a planning session, and of course, COVID got in the way. So we will wait, of course, until the COVID is under control, whatever that means, under control, to be able to bring everybody together. We have a proposal in place with funding from a foundation to carry this out. We have a plan. I'll be sharing that with both Dr. Smith and Renee, as well as the health plans for their approval as far as the content. So we're good to go. COVID got in the way, unfortunately. But with that, also, I will share with you that our supplies are at this point being provided primarily by local foundations, local donors, incredible people in this community, as well as Stanford University. We did get some supplies from the EOC, and we understand the priorities. So we are working with various folks, and we'll give you more detailed through your staff, if that's agreeable to you. Thank you.
Thank you very much. Let's return it now to the committee for questions to and comments, if any, to the staff. And Dr. Smith, heads up, we may pull you into this conversation as well, but let me start with Ms. Ellenberg and see if she's got questions or comments for Mr. Santiago, Dr. Smith, or any other member of the team. Supervisor?
Thank you. I have just a couple of brief comments and some requests for follow-up. I first want to say that I really appreciate the continued work of the county and CHP and our community clinics to work collaboratively to solve problems. And I believe that this is even more critical given the ongoing COVID-19 response and the impact on the county and our provider budgets. In particular, I'm glad to see the engagement of the clinics in expanding our local coronavirus testing options to assure that treatment and that testing and treatment are accessible, especially for vulnerable populations and underserved groups that have built trusting relationships with our community clinics. In response to the issues raised today by our speakers, I'd like to make a few requests for follow-up. First, to calendar meetings for strategic planning for August or September to include Dr. Smith, Renee, CHP, the community clinics, and Valley Health Plan to discuss strategic issues and partnership once COVID issues hopefully stabilize and more is known about budgets and state and federal supports available. I'd like the May Health and Hospital Committee report to indicate whether these meetings, when these meetings will be held. I'd also like to ask that Miguel and Renee meet with the clinics first as a group to review the proposal to adjust the PCAP eligibility limit in light of the county's framework for supporting contracted providers that was addressed with BHCA and SVCN, and to report back to the full board at the May 19th meeting. And secondly, to meet individually with the community clinics in June to adjust the whole person care targets and contract issues once additional information is available on the county budget and pending waiver requests, and provide updates at the June and August HHC meetings as part of the HHS director's report.
Thank you, Ms. Ellenberg. Let me just ask Dr. Smith and Mr. Santiago if for their reaction to those two requests.
Sure, we'll do that. As Dolores mentioned in her comments, we had intended to have regular meetings, but COVID sort of intervened unannounced, and so we have to get back to it, and we'll definitely comply with the request.
All right, so I'm gonna, Ms. Ellenberg, again, I want to just, there's so much in the mix here. I want to make sure that I bottom line the requests and the commitments.
Sure. I just want to correct myself, though. When I asked for Miguel and Renee to look at the asks for PCAP eligibility, I also should have included the whole person care and the GPP contract funding as well.
For June. Mr. Santiago, does that work from your standpoint?
Is that possible? Yeah.
No, absolutely. I think we're happy to meet. Some of those things, as you indicated, are dependent on getting flexibility from the federal government.
Right.
And so we can, at the very least, give you an update in terms of the
Great.
staff.
Thanks, Renee.
All right. Then we will also, if I may, was there a response that I just missed that went by me after a long day today on the issue of enrolling new clients electronically, an issue about which I know relatively little, frankly?
Yes, one of the things that, and again, some of these programs are federally funded, so we need some flexibilities, but to the degree that we have the flexibility, we're certainly open to doing that. I believe we already started to do some of those for whole person care in terms of verbally being able to enroll with verification later on. So I'll check in with the staff and give you a full report on those.
All right. When might that report be forthcoming, Mr. Santiago?
We'll do it on the off agenda memo as soon as I find out and confirm. We'll get back to you.
Thank you very much. So essentially, Dr. Smith, I heard the continued commitment to the long-term planning exercise as things we hope stabilize. Mr. Santiago, appreciate the commitment to explore essentially what federal guidance does or doesn't permit in the way of electronically enrolling new clients. And in the May and June timeframe, some discussion about the contracts that are in force today and about what the future might look like in terms of the provisions of those contracts going forward. Mr. Santiago and Dr. Smith, is that a fair summary on those 4 points? Yes?
Yes.
Yeah. Thank you both. Then the one question I would ask Mr. Santiago or Dr. Smith, either one, is as you all know, I was delighted by the fact that we were able to take action as a board recently on the healthcare access program. And again, my thanks to staff, including Mr. Santiago, but certainly others as well. But I'm curious to know, how does that impact or affect the PCAP program that we've had historically in the past? There was some reference to this, I recall, in the staff report, but because we had a full meeting, we didn't really get a chance to discuss it at the last board meeting. Mr. Santiago?
Yes, well, we have to assess, obviously, in terms of the PCAP, because as you know, the healthcare access program standardizes the eligibility and the financial screening across all our directly operated facilities. One of the things that we're also mindful in terms of PCAP is different clinics have different financial screenings and minimum fees. They're not necessarily standardized across all the clinics. So this is kind of an opportunity for us to go back and engage the clinics and seeing what they're exactly contemplating in terms of that proposal.
The piece that I was just starting to think a little bit more about was the PCAP eligibility, as I recall, was 200% of the federal poverty level. Am I remembering that correctly?
Yes, that's what currently exists.
And yet our healthcare access program essentially provided services for free at up to 400% of the federal poverty level, yes?
Yes.
And could I reasonably conclude that that could present some challenges for folks who are trying to make the PCAP system work at their community clinics if we were in effect competing with them at a much more attractive level in terms of funding?
Well, it's not necessarily competing, but it's a question of financial impact because obviously we would need to understand what it means not only for us, because we do have a limit in terms of the total budget available for PCAP, but then also what it means for the clinics once they reach their caps, whether they can sustain those eligibility standards and processes beyond our funding availability. So we have to talk through it a little bit more.
Let me ask that you fold that conversation into the report backs that Supervisor Ellenberg asked for in May and June, if you would, please.
Sure, absolutely.
Supervisor Ellenberg, I think you see the concern that I'm raising here and how it dovetails with the issues that you've already raised. All right, then with that direction, I believe that if there are no other comments or questions, and I don't want to cut you off, Supervisor Ellenberg, if there's anything else.
No, happy to move approval.
Then we have a motion to approve the recommended action on item number 8, which is to receive the report from the health system relating to community-based health clinics. And I'm happy to second it. And we're going to ask the clerk to please call out a roll call vote, even though it's pretty apparent here.
Vice Chairperson Ellenberg
Yes.
and Chairperson Simidian.
Committee and I, thank you very much. That concludes item number 8. And thank you again, Mr. Santiago and Dr. Smith and others. And Mr. Santiago, I believe we come back to you because under item number 9, we're going to get a beginning report from you. But given the fact that there are a number of moving parts to this item number 9, let me just ask the clerk if we have anybody queued up to speak on item number 9.
No speakers yet.
All right, well, here's what I'm going to do. I'm going to say, after we get through the next couple of minutes, last call on speakers. So once we're done with Mr. Santiago's initial report, I'll make a last call. And at that point, anyone who's in the queue will be heard, and otherwise we'll assume no one further to be added to the queue. Mr. Santiago, 9A, what would you like to share with us today?
Well, given the interest of time, I just briefly wanted to give you a summary of all the different packages. It's very detailed there in terms of what's available at the federal level. Of course, what's available and what's actually getting released and distributed are two different things. And that's a very concerning issue for us because some of the formulas that are being used at the federal government do not necessarily benefit health systems or cities or counties that are most directly impacted as a result of COVID. It's a big issue that we've raised not only with our congressional delegation, but also with a variety of other stakeholders to make sure that we communicate that effectively, both at the state as well as the federal level. And people are recognizing why it has to be a little bit more targeted funding available for areas that have been impacted, and especially for us, which, as you indicated in an earlier conversation of COVID, we've done the right thing. We've actually prevented deaths, and we prevented unnecessary illness in our community, but yet potentially we could be harmed as a result of doing well in that regard. So that's a big issue for us that we're tracking very closely and at the multiple levels, as well as the different funding streams. We also give you a little bit of an update because I know this is of interest to you, particularly Mr. Chairman, on the pharmacy and the medication assistance program that we're trying to align now that with the board approval of the healthcare access program. We outlined the series of steps and milestones. Of course, given COVID, both NARI and our pharmaceutical team has been deployed to a variety of other functions, but it's still very important. And we're aiming for the next month to give you a more detailed report in terms of our progress. One of the issues that we still need to follow up on is having a direct conversation with county council related to some of the legal and regulatory items. That will conclude my report, and again, available for any questions.
Thank you very much. Supervisor Ellenberg, comments or questions for Mrs. Santiago at this time?
Yeah, just one question and one request here. Thanks, Renee, for that report. As you look ahead to scheduling some surgeries and resuming some appointments that had been postponed, can you talk a little bit about how you expect those services to be resumed? Are there particular priority services or groups of patients that will be brought back online first?
Yes, I think Paul, as part of his report, can give you a little bit more details in terms of, because I know he's got a variety of different clinical work teams as well as operational teams that were working in this area. He could give you a little bit more detail.
Okay. I shall look to his square.
Thank you, Supervisor Ellenberg. And to the chair, would you like for me to go ahead and give my report and then also touch on Supervisor Ellenberg's specific question?
I'm fine with that if that works for Supervisor Ellenberg.
That's fine. Since I had just one other request, let me ask that too, because maybe that's more appropriate for Paul and Renee as well. And that's that as we shift to new performance metrics and performance-based payment programs, so I think this is still Renee, I'd like to request an off-agenda report that lists out the combined set of prime and QIP measures referenced in the report for this calendar year, along with any known targets or baseline performance levels at this point in time.
We'll go ahead. Yes, we'll.
Must be right. Okay. Then turning to Paul about the elective surgeries. Thank you.
And Mr. Lorenz, why don't we simply go ahead and say that we're going to take up your report at 9B. But first, let me just check in with the clerk. We have folks who are teed up to speak on item 9 at all, any component or part of it?
We have one speaker in the queue.
Let's go ahead and hear from that one speaker, if we may, Ms. Ellenberg, and then we'll go to Mr. Lorenz. He'll give his report and he'll respond to your specific question. And let's have our speaker, please.
The next speaker is Robert Aguirre. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak once the timer begins.
Mr. Aguirre, are you there, sir?
Okay. Crap. Can you hear me now?
Loud and clear,
Hello?
sir.
Okay. All right. So I would like to comment on the fact that although we're taking care of all kinds of clinics and everybody that is going in to get treated, we also have a lot of places where people are in shelters that are not run by the county or the city of San Jose. There's churches and other organizations that are taking people in, whether it's in a Safe Park program or in a shelter within a building. And they don't get the funding that the county is giving or the city is giving to any of the other government-run or authorized facilities. They may be run by other organizations. But I know that one of the things that we have been trying to get are the infrared thermometers, so that we can check people as they come in and make sure that that they are taken care of. That if they are showing symptoms, even as elevated temperatures, we can then at least identify those people. But many of the private people that are helping out with this situation and have been helping out, some of them for years, do not have these kinds of fundings available for these types of things. And I think it's very essential that we recognize that and provide a place for people to be able to apply for and get these kinds of things, including hand sanitizers and other things like that. Thank you.
Thank you for your comments. We go now to item 9B, and we're going to hear from Mr. Lorenz, who will give his report and respond to the earlier question from Supervisor Ellenberg. Thank you.
Thank you, Chair Simidian and Supervisor Ellenberg. I first of all have to stress for the group, and I think we all have a pretty deep appreciation for this now, that the measures taken by the public health department in this county have really allowed the hospital to not only respond to the COVID-19 situation in a very responsible and responsive manner, but also has allowed us to prepare. And I think the numbers are very telling when you look at the county-wide dashboard. Valley Medical Center, O'Connor Hospital, and St. Louis Hospital have an enterprise dashboard that also looks at the number of COVID patients we're caring for, our bed capacity, and really gives a sense of where we're headed relative to our preparedness. What I wanted to share with this group is that today we have about 5% of our total acute care population that are COVID positive. That means that 95% of our acute patients that we're caring for in the 3 facilities are non-COVID related. And of course, there to receive other health care. And a lot of our preparation has not only been around caring for COVID positive patients, but making sure that our patients and staff in general are being attentive to making sure that we don't have any further spread or further problems within our healthcare facilities, but obviously in our community. The numbers also show that we have over 50% of our acute care bed capacity available from our typical numbers that we would run at the 3 hospitals. And of course, when we look at those numbers, we're also looking at our financials. So although we're aggressively looking at reimbursement for COVID-19 related expenses, we're also looking at how we're performing financially during this crisis and making sure that whatever we do going forward, that we think strategically about how to come out of the COVID-19 crisis in a manner that minimizes the financial implication and impact to the system. And with that being said, a couple things have come out, and we're not the only system that is looking at this. One is looking to bring back patients via elective procedures, surgical cases that Supervisor Ellenberg has just mentioned. Our effort is to make sure that we do it in a very responsible manner relative to making sure that the patients and staff are well protected and understand the processes going forward. We are working closely with each of the respective surgical departments at the 3 hospitals and identifying patients that we consider to be a priority. In other words, patients that have put off their surgical procedures in light of the COVID-19 situation, where we feel that it's in their best interest to come in for that particular procedure, if you will. So we were actively reaching out to those patients and beginning to schedule those patients. We are looking to begin on May 4th, which is next Monday. And I think we are in a much better position today because of our testing capacity. And what I mean by that is not only are we going to be testing the patients, whether they're symptomatic or asymptomatic. They're symptomatic, more than likely we will not have that procedure done, but put it off unless it's an emergency. We are also now testing and providing testing to all of our staff that are providing critical services. And those are inclusive of staff that are asymptomatic. So as we move forward through bringing in the patients from an elective standpoint, we're in a much better position to ensure that we're protecting both the patients and the staff going forward. I also wanted to, and I'm not sure, Supervisor Ellenberg, if that's responsive to your question. I do have other updates that I do want to give.
That's actually very helpful, Paul. I apologize for getting ahead of myself in the questioning. Thanks.
I do want to mention, and Renee Santiago alluded to, that not only are we looking at elective cases, but we're also looking at other services that we provide as a healthcare system that we can begin to ramp back up. And that's also in the area of primary care, specialty, as well as some service lines that we had started prior to COVID-19 so that we can bring those services online sooner than later, given our ability to do so. And to just give you some sense of that, prior to COVID-19, we started a number of different initiatives, including robotic surgery. We were looking at bariatric services. And the reason I bring this up now is that it's really important as a healthcare system that we continue to focus on caring for the patients that we were caring for prior to COVID-19. We anticipate there to be a lot of pent-up demand for our healthcare system, particularly for our safety net system, given the changes in the economy relative to people that may end up being further underinsured or uninsured. And so it's really important that we ramp up as quickly as possible, not only from a community-wide health access perspective, but also from a financial perspective. The other update I wanted to provide to both of you and to this committee is it's been close to 13, 14 months since we acquired O'Connor Hospital and St. Louis Hospital. And you probably have noticed that we refer to ourselves as an enterprise or as hospitals and clinics. And we really haven't taken the step to rebrand ourselves. But we've done a lot of research and we've worked very closely with the county executive office in coming up with a plan that we believe would further reflect who we are and how we operate in terms of healthcare services in this county. So what I wanted to do is just give you an update to let you know that the next Health and Hospital Committee, we will provide you our recommendations relative to rebranding the healthcare delivery system, as well as possibly some name changes that we're looking at. And during this process, I also want to share that we have engaged the community at large relative to focus groups, both externally and internally, on how we can proceed with this rebranding of the system. And I think we would all agree that this is probably a good time to do that, coming out of moving forward through this COVID-19 crisis, to make sure that people understand who we are and what we have to offer the entire community as a healthcare system. So with that being said, I'm happy to respond to any other specific questions that you may have.
Supervisor Ellenberg.
I have no further questions. Thank you.
Thank you. Mr. Lorenz, I had not anticipated I would be weighing in on rebranding issues today, but since you've raised the question, and I applaud your courage, I do just want to make this observation. Going forward, I do understand, I think, the fact that now that we are a 3-hospital system and have incorporated 2 hospitals into our organization and created effectively a new system, I understand the need and desire to give some careful thought to how we brand. And in general, my view on this, notwithstanding the professionals, is that this is as much an art as it is a science. So I'm not inclined, and here's the good news, I'm not inclined to second guess such efforts going forward, unless I think something is really ill-advised, in which case, as you know from working with me over the past 7 years, I'll feel free to step up and offer my observations. The one thing I would just ask you and your colleagues to keep in mind, is it is hard for people to develop brand loyalty if there is no brand consistency. And we have a number of nonprofits who have gone through, I think, at least 3 name changes during my 7 years on the board. And I have people in the community who can't keep track of who is doing the good work in the community, literally because the name changes. And I'm sure someone thinks that these are inspired changes. But again, people can't develop brand loyalty if there isn't some brand consistency. And I would just ask your team to be mindful of that as you go through the exercise. I promise that's it from me today on the issue of branding. And anything else from you before we go on to 9C, Mr. Lorenz?
Not at this time, but I do have to say that your comments are right on. And I think when we do present the proposal, those will be obviously taken into consideration.
All right. Thank you so much. Then I'm going to say thank you to Mr. Lorenz, and we're going to go on to 9C. And 9C, of course, is the verbal report from the Director of Behavioral Health Services. And I believe that Ms. Tullies, who is still on the line with us. Yes?
And if I may, before Tony gets in, this is going to be Tony's last meeting as Director of Behavioral Health. And so I wanted to personally, and I'm sure also yourselves, extend a warm thank you for her 5 years and plus of service to our county. She led many of our reforms, as well as many of the changes in our network and programming. So with deep appreciations, obviously we would like to have celebrated her departure in a much different time, but nonetheless, we certainly appreciate it. And at the same time, obviously, we want to thank Sherry for stepping in at the interim as well.
Thank you so much. Ms. Tullies.
Okay, hello. There's quite a bit in the, I think what I'll do, given the time, since the question came up, talk a little bit about what we're doing with BAP and EPS, and a quick sentence on what we're doing with NetSmart and MHSA, and then answer any questions that you'd like. Sherry Trejo is actually on the call today for the first time. She'll be the acting director starting next week. And I think that she's going to do an excellent job. She's got an excellent team. We've got great staff during the transition. So for COVID-19, we've done quite a bit of work, and the work has been focused in many areas, but one of the most important has come from the hospital, from Paula Renz and Curtis Osashi, about how we could help them prepare for anticipated surge in both EPS and in BAP. So very rapidly, and I want to give credit where it's due, Sherry's run this operation. We consolidated 2 of our clinics, and we did that because of the geographic space where our urgent care center was right next door to EPS. And what they had asked for is additional facility and capacity for a big surge in EPS. So we moved our mental health urgent care just down the way to our central wellness and benefits center. People are providing both the outpatient services and the urgent care services. And while it was an adjustment for staff, and of course, on all these immediate changes, we've been very thoughtful. We are providing the services that are necessary, very much necessary to all residents, including those individuals who are coming in because of the anxiety that they're feeling about the virus. We're seeing a new population coming into our services. Secondly, and I think the thing that's taken quite some time, but it's been effective, is we had a lot of clients that were in BAP that needed placements in residential care facilities, institutes of mental disease. We needed to move them out, but because of their condition, they needed to go to particular types of levels of care. So we worked very, very closely and continue to work very closely with Curtis and the BAP team, our 24-hour care team, and our staff to look at those and the public guardian, to look at those individuals who were ready to step into a longer term, initially crisis residential, and then into our new assertive community treatment programs. Very proud of the work that's been done. Many clients moved out of BAP. What that allows for BAP is that they have 2 wings now, one for individuals with acute psychiatric needs who have the virus, and another wing for those individuals with acute psychiatric needs who do not have the virus. So that again was a partnership with the medical center. And we're continuing to look at other facilities in the county that could expand services, not only during COVID, but post-COVID. We have a number of staff who are working in the hotels where people have been assigned coming out of custody. And we have staff that are working in the federal center down in the convention center. So there's a lot going on with behavioral health playing a very active role in this. Questions by the supervisors?
Thank you. Let me go to Supervisor Ellenberg.
Tony, I am going to miss you. Let me just start with that. I have really appreciated working with you over the last year and a half. Even before I started in this office, you were a great mentor and resource, and I appreciate your very forthright style, your commitment to this work, and your vast wealth of knowledge and experience. So thank you for working with me. Thank you for everything that you've done for our county. I'm going to make a couple of comments and requests for future meetings, which obviously have nothing at all to do with you, but of course the great work that you started with needs to go on. So thank you. And one of the pieces in general that I really want us to be thinking about in this committee is that under the current COVID, with the current COVID-19 emergency, I think it's really abundantly clear to everyone that the mental health needs in our community are really even more acute as people work through isolation, anxiety, and interruption of their normal behavioral health services due to physical distancing. And I'd like to ask that we do a deep dive discussion on behavioral health services soon and prioritize the discussion of the needs of youth, our unhoused community members, and perhaps other key groups in depth to understand what adjustments we need to make and new approaches that we may need in this post-COVID world. There was so much good work that was just being stood up with regard to our unhoused community. Just before all of this started, I realize and understand why some of that is necessarily pulled back right now, but I want to make sure that at our very earliest opportunity that we have an opportunity to revisit and reinvigorate this work and make sure that whatever ground we've lost, that we make up forthwith. So I don't have a specific month for that. I would leave that to my committee chair and his very capable staff to see where that discussion can fit in. The second piece that I want to raise is that we have planned to revisit the school mental health services referral that I introduced last October as part of the May work plan for HHC. And to me, that remains a really critical issue. And I am sure that we are all extremely hopeful that students will be back in their traditional settings for the 2020-21 school year. But in light of our current situation, I want that conversation to happen whether or not kids are going to be back on their traditional brick and mortar campuses in the fall, because frankly, either way, the need for services is going to be extraordinarily high. And we have an opportunity to partner with our school districts and with the County Office of Education and our very own School Link services to really look at how we might expand what we're able to offer and how we're able to provide support for students who are struggling. So thank you.
Well, you're welcome, and thank you for your comments. And I know that in both of those areas, we've had conversations internally and with the providers, and Sherry and her team have been very focused on that.
Good. Well, Sherry, I'm looking forward to working more closely with you as well.
She'll be there. Thank you.
Thank you, Supervisor Ellenberg, and Ms. Tullies. Let me add my thanks as well. And first, just a nod to my colleague, Supervisor Ellenberg. I thought very artfully embedded some not terribly subtle hints about the work plan of the committee in the months ahead. So I just wanted to know that they were received, Supervisor.
I'm learning. Subtlety gets me nowhere, Joe.
Welcome to that hard reality, indeed. Thank you. Ms. Tullies, I say with a smile, but also with appreciation, quite seriously, I look forward to inviting you to both the groundbreaking in 2022 and the opening ceremonies in 2023 for what I still think of as the Adolescent Psychiatric Services Facility. And I just wanted to thank you for your efforts in moving us towards having a tangible result in those conversations. So other than that, I have nothing else to offer or ask except to wish you well in the next chapter. And as I said, keep looking for that invitation in the mail, because I'm hopeful that we'll be able to get it to you sooner rather than later, okay? And I think that takes us to item 9D. And that would be this report from the CEO for the Valley Health Plan.
Good afternoon. Can you hear me?
We can indeed, Ms. Rosas.
Great. Thank you so much. And again, would just like to thank Toni Tullies for being such a wonderful colleague and mentor, and just say how much I'll miss her. It's been wonderful working with her over the last 2 years. In terms of our activities, I'd like to give an update on COVID-19 and what we've been doing. We've spent a significant amount of time and effort in ensuring that our providers and our members have accurate information, both in terms of billing for telehealth and for ensuring that our members can access telehealth. There were changes at the federal level, which allowed additional flexibility in using various modalities for accessing providers. But in addition, we have been working to expand our telehealth capabilities. We've always had that with our covered California and commercial line of business, but we are looking to expand that in the very near future to Medi-Cal, and we're really excited about that. In addition, we have at least 6 of our staff are now working as disaster service workers, supporting the hotels that are housing homeless and vulnerable individuals. And finally, very proud of the team at Valley Health Plan. We were able to be 98% telework within days of the order. And we are very carefully tracking our metrics on performance, and we'll have a very in-depth report next month. But we can tell already that our productivity, while having an initial dip, is now at or above where we were prior to the stay-at-home order. So kudos to the team, very proud of the work we've been doing, and happy to take questions.
Thank you very much. Supervisor Ellenberg, questions if any?
No questions. Thanks, Laura.
Nor do I, so we'll say thank you very much, and thanks for hanging in with us through what I know has been a very long afternoon.
Thank you.
That takes us to 9E, the report from the Emergency Medical Services folks. Who'd like to present on this item?
I will, supervisors. This is Jackie Lowther from Emergency Medical Services. Good evening, everyone. I just have a brief update in addition to what you have before you. We have been, over the past 45 days or so, the compliance is fine. EMS has been adjusting deployment as as the call volume does. We are still approximately 20% below that from pre-March 17th, but rising slightly with occasional daily spikes, such as over the weekend and on Monday. Hospital transports are still below that of pre-March 17th, but still gradually increasing. There was a little bit of that we have been monitoring. Cardiac, chest pain, and stroke transports are increasing, with a notable increase in STEMI transports, although the numbers are still a little bit small. And cardiac arrests appear to have returned to a new baseline, slightly above that of pre-March 17. However, cardiac arrests in the 60 to 69-year-old age range still remain increased over previous baseline. So it was, with a lower volume and less people calling 911, we've been keeping an eye on sort of ongoing daily data monitoring for response volumes, non-transport proportions, and keeping an eye on cardiac related strokes, STEMI, sort of overdoses, behavioral crisis, alcohol intoxication, and domestic violence. So those are the things, and working in great partnership with in the Unified Command, giving data over to the EOC. So staying busy with all of that. You know, the contract ambulance performance, first responders are all doing a great, fabulous job. And for you, Supervisor Simidian, wanted just to note that our stroke system update, we did get our data over to our partners as requested last week, and we'll have everything in place to give a great report for the next HHC meeting, and got our contract with Get With The Guidelines in its final stages, so that we will be getting stroke data directly from all of the hospitals, probably within the next week or two, which will certainly make everyone's life a lot simpler. So the Stroke Foundation is very happy about that. And also in our report is our first report of the abuse and neglect data that we started collecting on January 1. and we'll be able to work that through just a little bit more as time goes on. This was just our first blush at it, and I'll be happy to answer any questions you might have.
Thank you. I do have a couple, but Supervisor Ellenberg, anything you'd like to begin with?
I just want to express appreciation, Jackie, for the first quarter of the domestic violence data. That's useful and informative, and I'd like to see that included on a quarterly basis going forward as part of the EMS reports to help round out the picture over at least a full year.
We also have, in addition to that, I looked up as far as the non-transports to ensure, and I'll include that next time, that all of the non-transports, that the police were on scene and sort of what happened is the after effect. And of those, the 3 of those left with the police department, all 17 had PD on scene with them. So I just wanted to take it a little bit further and find out what happened to those.
Yeah.
And so we'll include that too, and have a couple of heat maps to go with that. And so we'll expand that as we move forward.
Great. I think that can be really helpful to other strategies and programs that we're doing. Thank you so much.
And Ms. Lowther, I just wanted to follow up a little on the stroke data. Can you hear me loud and clear?
Yes, sir.
Thank you. I know we got the most recent data in. Do I understand that the expectation is that the first quarter data for this year, 2020, will be delivered in May? Is that correct?
Yes, sir.
Okay, thank you. Appreciate that. I just wanted to confirm that. And then I wanted to ask a couple other questions. One is, where are we on data? As you'll recall, I had expressed concern about the fact that we were not getting data from quarters gone by. First and second quarter of 2019, what about that data?
Dr. Miller is working on that, and once we get with the guidelines, I've requested, as have you, if we can go back with all the hospitals and request data to complete 2019. So once we actually get the contract in place and see what we can get for to complete 2019.
Could I ask that you specifically provide a status report on that effort at our next meeting of the Health and Hospital Committee when you present, please?
Yes, sir.
And that, thank you. And then the other question I had is, going forward, is this data we're going to continue to provide quarterly? I understood there was some talk about going twice annually, which is a source of concern for a couple of reasons, but why don't I let you respond before I document concerns about what may or may not be an issue.
We get it a quarter in the rears from the hospitals because they wait until the patients have been discharged from the hospital. So it could be on a quarterly basis, but it will be in the rears. So we get the last quarter completed, and that means what was the final disposition. So we can get it on a quarterly basis and provide that. So if that is what you're...
I'd like to ask that we continue to get it and provide it on a quarterly basis for a couple of reasons. One is, I think the information is most useful when it's as close to real time as it possibly can be, understanding the lag that you're describing. And the second, quite frankly, is that given the delays we've had over the last year and a half, if there's a further problem developing, and my hope and expectation is that there won't be, but I'll want to be aware of that further problem sooner rather than later, and twice annually just allows a little too much slippage to stay on top of these things. So can we ask that that information be provided quarterly then?
Yes.
All right, thank you. I don't have anything else on this item, and I'm looking at Supervisor Ellenberg, who appears not to. Thank you, Ms. Lowther, and thank you to Dr. Miller as well. Can we go on now to item F, which is to receive the report relating to federal health policy and the budget landscape? And do we have Mr. Margolin still with us?
I'm here.
Mr. Margolis, good to see you. Thank you for staying through us, a long meeting today. And I'm going to make two requests of you. The first is, notwithstanding the hour, please don't feel any need to shortcut the report you're going to give us, because if ever we needed to have a full and complete, excuse the redundancy, a full and clear picture of what's happening at the federal level, now is the time. And the second thing is, I'm going to ask you not to speed talk us through it as you sometimes do, because I want to make sure that we have time to process what you're sharing with us. So with that set of requests, please proceed, and thank you again.
Certainly. Thank you very much, Mr. Chair. I will be comprehensive, and we'll talk at the appropriate pace.
There you go.
The first point I would make here is that this is obviously a very complex process at the federal level responding to the COVID epidemic crisis. There have been a number of bills, and I'm going to walk you through the 4 bills that have passed over the last month or 6 weeks and give you some sense of what this 5th bill in the month of May might encompass, what the points of contention are. As Renee said earlier in his presentation, in this legislation, much of what we've been concerned about has been the way formulas have been constructed and how California has fared in those formulas. And I'll reference that as I go through this accounting of the legislation. The monies and the policies that have been developed at the federal level fall into sort of 3 general buckets, and I'll start by referencing the 3 buckets. There's a public health response, a need to mobilize the resources to help the work of Dr. Cody and her colleagues do what they need to do to bend the curve and control the epidemic. Then there's obviously a second bucket of patient treatment resources. How do our patients receive the highest quality possible, of the highest possible quality care in whatever setting they're in dealing with COVID? And then the last category, Paul Lorenz referenced in passing in his comments, and it has to do with the basic question of provider finance. How do we weather this crisis, which is, again, a public health crisis, and it's a patient care crisis, but it's also a provider finance crisis in that with a loss of revenue as a result of revenue streams being disrupted and diminished, there is a danger here of a critical loss of resources that will be needed to keep doors open, to keep staff employed, and to keep our system capacity intact. So that's the third piece of all this. So the 4 bills, let's start with the first bill, March 6th. It was really a supplemental appropriations bill, $8.3 billion, not a very large measure, as you'll see as the dollars continue to grow as each bill passes in this process. But it started off by primarily providing the federal government with dollars they needed to fund their efforts to develop a vaccine, to run their infrastructure. There was some money for local governments that came out of that first bill. There was $1 billion or so that was moved through the Center for Disease Control to state and local governments for preliminary response to COVID. There was also an effort to loosen the telehealth reimbursement requirements. Again, as patients can't come in for their in-person visits, a major theme here in terms of preserving solvency of the system, in addition to access to quality care, is allowing for expanded use of telehealth, which traditionally has not been reimbursed as robustly as personal health care has been, personal in-person visits have been. So this first bill began to relax the telehealth standards, and they've been relaxed further as the bills move forward. The second bill was the Families First Response Act. About $100 billion up to $300 billion still being estimated in budget impact. That dealt with funding sick leave, medical leave, expanding access to that resource. It also had a particular provision that's of significance to California, in that it increased temporarily the matching rate for the federal government under the Medicaid program by 6.2% for every state in the country. The LAO here in California, in our state legislature, has preliminarily estimated about a $5 billion benefit to California. And it's the first of, again, several changes designed to help out state governments and local county systems weather the financial storm that we're currently engaged in. So again, a matching rate bump that's going to last for the length of the COVID emergency. So that will last obviously for a period of several months, if not longer. Then on March, we now move to the third bill, the third package, March 27th, the biggest package by far, the $2 trillion plus CARES package. A number of things in this bill that are worth noting. The first I'll note is the elimination of the DISH cut, the DISH funding cut that Santa Clara County was facing. It was a $30 million preliminary cut in financing, and we've been working to defer that over multiple years. It has been deferred over multiple years, and actually the Congress this time eliminated the cut. That first year cut is gone, $30 million gone. They've then taken the second year DISH cut set for 2021. It's still set to take effect in December 2020, but they've chopped that in half. Again, the DISH issue will continue to be an ongoing struggle for us, but some good news in this CARES Act proposal. They also provided $150 billion for state and local governments for the first time to receive. Again, the first package of state and local government assistance, badly needed. As Renee indicated earlier, the formulas haven't always been beneficial to us, and this first package, $150 billion, had a formula that was not especially beneficial to California. It provided every state with a minimum allocation, no matter what their population, of $1.25 billion. So that meant states with very few people and maybe very little COVID impact got their $1.25 billion. California then got, along with the other large states, a pro rata share of the remainder after the minimum allocation was distributed. And we ended up with a significant chunk of money that will help Governor Newsom in this budget crisis, but it's not going to be proportionate to what we should have received given our need and our size. So it's a formula issue. This CARES package also put $100 billion into the hospital and healthcare system. It was the first allocation of direct assistance to providers. And it's badly needed, although once again, as Renee suggested, there's a formula issue here in that the first 30 billion of 100 billion was allocated based upon a formula that was tied to Medicare fee-for-service. That was the formula. And that's not even though Santa Clara County received some money from this first allocation, Medicare fee-for-service for systems like ours that again have a relatively small Medicare population compared to Medicaid, this is not a very generous formula from our standpoint, from the standpoint of other Medicaid providers around the country. And it's good the money got out there quickly. It's good that we received some money from this first tranche, but the formula was criticized widely. House Democrats tried in the CARES Act to accomplish two other objectives that are worth just noting because they didn't succeed. And this fight on these two objectives will be part of the continuing battle in the next bill. The first involved getting our 1115 waiver subject to elimination, closure. Our waiver's ending this year. We're fighting for renewal. The state's trying to get that automatically renewed for an extended period of time. There's no time to do a waiver negotiation with the federal government in this current environment. We're also likely in this current environment, should we be forced to do a waiver negotiation, we're likely to end up not getting the attention we need to get the things we need in that waiver extension. And we already are facing a shortfall in revenue with the new waiver being suggested as a much smaller waiver than our current waiver. So rather than fight for a smaller waiver in an adverse environment, the state's trying to just get our current waiver, the larger waiver, rolled over for a period of time. There was a provision that Speaker Pelosi put in the House version of the CARES package, didn't make it into the final version, that would have given us the authority to automatically have that happen, the automatic rollover. The second provision involved the MFAR rule, which is still pending. This is the rule we've talked about in the past that involves the way in which states provide a match under Medicaid for federal payments. The MFAR rule, which is supposed to create fiscal accountability, that's what the rule stands for, fiscal accountability rule, Medicaid, would actually have made our current matching system blow up, and our ability to draw down federal monies in California and some other large states around the country be significantly compromised, so that potentially billions and billions of dollars, maybe tens of billions of dollars, would be put at risk. There was a provision that Speaker Pelosi tried to advance that would have put a moratorium on MFAR, given the COVID crisis. That didn't make it into the final package, but Speaker Pelosi and her team have not given up on these provisions, and they'll be part of the battle in May over the next bill. The fourth bill, though, we haven't gotten to the fifth. We'll get to the fifth bill in a minute. The fourth bill was the Paycheck Protection Program and Healthcare Enhancement Act. It just was approved several days ago. That was the fight over the Paycheck Protection loan program where the dollars were exhausted. Small businesses weren't able to get their Paycheck Protection dollars, were very unhappy, and there was this agreement on a bipartisan basis. The fund had to be reestablished. In the end, they approved $315 billion. No argument there, but Democrats argued, and this is why there was a fight for 2 weeks, that you can't just simply do paycheck protection when we need even more money for hospitals, and we also need even more money for local governments. So the reason why it took 2 weeks is there was a standoff over more hospital money and more local government and state money. The Democrats won on the hospital money. $75 billion was added to the pot for hospitals. They lost, at least temporarily, on the local government, state and local government financing issue. That's been deferred for the month of May, into the month of May, and a debate during this fifth bill. What was achieved here was $75 billion of additional money for hospitals and other healthcare providers that qualify, and actually $25 billion to expand COVID testing, an issue that you talked about at great length. $11 billion of that $25 billion is going to be expended at the state and local level. We don't know how it's going to be distributed yet. This just happened a few days ago, but there's going to be additional federal resource available for state and local testing, methodology to be determined. So negotiations are now underway on a fifth package because the fight's not over, the resources still are needed. And they're off to a rocky start in that Mitch McConnell, the Senate leader, said that not only was he against state and local dollars being provided, additional money being provided in this last package, which was just approved, but he thought it shouldn't be taken up in the fifth package, the one to be dealt with in May. And he suggested that states should instead turn to bankruptcy as an option. As you know, Supervisor Simitian, from your service in the state Senate, bankruptcy is not an option for a state. When you say bankruptcy to a state, you're really talking about massive budget cuts and education funding, public safety funding being eviscerated. So Senator McConnell's recommendation is not only illegal, can't be done, states can't declare bankruptcy, it would lead to this kind of fiscal chaos and the gutting of really critical services. So House and Senate Democrats are going to not give up, though, and they're going to make state and local rescue dollars, which will be critical to the state of California and Governor Newsom as he develops his budget, may revise the budget to fight over the summer. They're going to make that a key issue for the month of May. They're going to also raise our waiver issue again and the moratorium on the MFAR rule. There are other things they want to accomplish in May. They want, the whole methodology that we've been critical of, involving initially Medicare as the formula for hospitals getting their money, and then they've made changes in that methodology, but those changes have been equally criticized. So the House Democrats would very much like to create a methodology in statute that really addresses the COVID crisis and that is fair to all the providers and better directs the money. I don't know if they'll prevail in the methodology battle, but that's also going to be a battle that will be fought during the month of May. And there's one last item I'm going to talk about, Mr. Chair, that will be battled over during the month of May, and it directly relates to your earlier discussion with Dr. Cody about what Santa Clara County needs to do to reopen. And it's the issue of public health resources. How do we actually do the contact tracing, and how do we actually deal with the isolation of people who've either been infected or might be subject to infection, having been in close contact with someone who had COVID? How do we deal with all that at the local level? So this week, two health officials on a bipartisan, two health officials who've served different administrations put out a letter signed by 13 other prominent national health leaders that essentially recommended $46 billion for the fifth bill for the May package to be dedicated to a public health investment to combat the COVID-19 crisis. The two lead signers are Andy Slavitt, who served as a CMS director in the Obama administration, and Scott Gottlieb, who ran FDA for Trump in the Trump administration. And Scott Gottlieb is currently an advisor to President Trump on these issues. So Gottlieb and Slavitt came together, did this letter, and said we need $46 billion. We need $25 billion. Let me stop for a second. They acknowledged that in the last package that was just passed, there was $25 billion for testing. They said that's an important step, but we need $46 billion on top of that, and here's how that breaks down. They want $12 billion to hire 180,000 contact tracing workers. That's the sort of minimal estimate nationally of what's needed to really do adequate contact tracing. They want $4.5 billion to rent vacant hotels so that people who are either infected or exposed to individuals who've been infected and identified during the contact tracing, to create a place for them to self-isolate. And they estimate that that's the amount of money needed to create a national capacity. And the third piece of this is they want $30 billion to offer, to be applied to 18 months of income support. They're suggesting $50 per day for those who are voluntarily self-isolating but have economic concerns and reasons to not self-isolate and need some kind of financial support if they're going to self-isolate. So Slavitt and Gottlieb put this forward on Monday. It's out there, and House staff that we've talked to over the last day have made it clear that they're going to be advancing this proposal, or trying to advance this proposal during the May debate over the fifth package. So that's a summary of what's going on, Mr. Chair. I'm happy to respond to any questions you might have.
Thank you very much. Supervisor Ellenberg, comments or questions?
I was actually struck by the proposal that of public health supports to hire contract tracers and do the financial supports for people to isolate that I've been thinking about and wondering how we would do. And this I think is a really helpful piece. Thank you for everything that you shared. It just so happens that last piece really triggered some thoughtfulness about what we can be working on here. Thanks.
Very good. Thank you.
Let me ask Mr. Margolin, part of the reason I was so anxious to make sure we got a full report from you today is that, as you know, we're going to be talking in our Federal Affairs Advocacy Task Force about where we go from here. And, you know, I'm always very realistic, or at least I try to be, about the fact that Washington is not always waiting with bated breath to hear from Santa Clara County about what we need. Having said that, do you have thoughts that you could share with us today about the means by which we may be most effective in communicating our county's needs, particularly as it relates to, I know, you know, certainly our staff has been on this, individual members of our board have been engaged in reaching out to members of Congress, but your thoughts about how we can have the greatest impact in making the case, understanding that the whole country is making its case right now.
Well, Santa Clara County has been, I think, relatively effective in elevating issues, and we've benefited from having a powerful congressional delegation. We have two members who are especially close to the speaker and who are able to advance issues, Congresswoman Eshoo and Congresswoman Lofgren, both of whom can fast track issues directly into whatever negotiation goes on. And they in fact did that over the last several weeks, and I'm sure we'll continue to do that. So I think it's more than anything else, a question of us tracking these issues closely, developing our ask lists carefully, because you can't get everything you ask for, obviously, and you can't ask for too much, but prioritizing the issues that have the biggest impact on Santa Clara County's ability to deliver services and to protect the population. And again, we're going to have a battle throughout the month of May, where again, I think we have an opportunity to influence the federal discussion, and we just need to stay on top of the issues and continue to communicate.
Thank you very much. I'm smiling even if you can't see it, because when you suggested the importance of prioritizing, it's a suggestion I make to everyone who comes to my office, but of course I didn't really want to have to do that myself. So understood. And I do think for county leadership that's probably something we need to be mindful of as well in our staff communications, which is while being advocates for all that we think is truly needed to deal with the challenges of the moment, we probably are going to have to identify those items that are at the top of the list and make sure we make a especially important case for them. So thank you. Supervisor Ellenberg, anything else before we let Mr. Margolin go and wrap the meeting up?
Not a thing.
All right, Mr. Margolin, thank you as always. Keep yourself well.
Thank you.
And ordinarily at this point, I would say we're going to adjourn to our May 26th meeting. The one caveat to that is Supervisor Ellenberg and others, we may call a special meeting specifically on the subject of testing and how to move that issue forward. Supervisor Ellenberg, I think you and I both are of the view that some focused attention on this subject would be worthwhile. I don't want to put words in your mouth, but I think we're in much the same place on that. So without objection, hearing none, we are adjourned until May 26th with a possible announcement of a special meeting on the subject of testing. Thank you all so much. I know it's been a long afternoon. And thank you everyone for the work you've been doing under difficult circumstances. Take care.